Morning. I hope you can see and hear us okay.
I can, Ms. Carey, thank you. I understand there have been travel difficulties this morning, which I, of course, have avoided. I hope everyone's not had too awful a journey in.
No, I think we're all here now, and the first closing submissions this morning are coming from Miss Gray, King's Counsel.
Thank you very much. Miss Gray.
My lady, I make these submissions on behalf of NHS England. We'd like to start by thanking this inquiry and its chair for a productive and helpful set of hearings. In particular, we'd like to record our appreciation of the hard work of the inquiry team, including a thank you to the inquiry and Hestia staff for their first-rate, behind-the-scenes support of witnesses and attendees. We say thank you for not making this set of hearings personal. The inquiry has generally focused on issues rather than individuals. Our next thank you is to all those witnesses who came forward to give evidence, sometimes at a high personal cost. It's not been easy, especially when critical and sometimes intemperate comments on social media accompany the public appearances. Finally, we say thank you again to the NHS's staff, who did extraordinary things at a high personal cost during the pandemic. The NHS's overriding goal throughout was always to treat as many patients as possible with the resources that were available. That inevitably led to overstretching those resources, including our staff, causing exhaustion and trauma. The inquiry has shone a light on these costs. We'd ask it to record how magnificently staff, including outsourced workers and private contractors, rose to the challenge, and to ensure that this rings out clearly from this module's report. The inquiry is charged with producing a factual narrative account of the response in this module of the healthcare sector, and with identifying any lessons learned as a response. We'd like to make 5 very high-level points regarding that task, concerning, first, the context in which the NHS operated, an unprecedented global pandemic of a scale not seen for over a century. Secondly, structures for dealing with emergencies. Then dilemmas, balances and risks. Fact-finding about decision-making, and finally, the topic of recommendations. Things that we're not covering orally include many areas of complexity and debate, such as critical care capacity, overwhelm, or specific services such as NHS England. We simply can't do justice to many complex matters in brief oral remarks. We'll do so in writing. But no one listening now should conclude that because we can't address an issue now, it's being disregarded. To take only one example, we recognise the importance of the inequalities investigated. There's a journey here which requires much further work. As Ms. Pritchard said in response to a question from FEMHO about the structural inequalities the pandemic exposed, I agree we need to do more. Moving to the 5 themes, first, it was a global pandemic, a genuine, unpreventable catastrophe. At times, the fact that the world was in the midst of a human calamity has seemed remote from these ordered hearings. Burial sites were overrun and mass graves were dug in Iran and Ecuador. Italian hospitals were overrun, Spanish care homes abandoned. These were the images before decision makers in the first months of 2020, painting a frightening picture of a disease for which there were no known treatments or vaccines. COVID has caused around 27 million deaths globally, directly or indirectly. It was a tsunami which came at us hard and fast. NHS England coordinated the NHS response to this disaster. We took this task head-on and quickly by declaring a level 4 emergency, the highest level of response, giving us the authority to pull all the available levers to increase capacity. From the start, we were trying to provide as much care as possible to patients by stretching the resources we had. Sacrifice was an inevitable consequence, and sadly, suffering was an unavoidable reality when reacting to a pandemic of this scale. This applies to staff. You've heard from Ms. Pritchard about how more headroom would have allowed a more measured build-up, but realistically, we will never build enough headroom to avoid surge measures. It also applies to patients who experienced the postponement of care or diluted care or curbs on visits. But all of these were fundamentally necessary steps, even if there were issues and lessons about the exact balance struck. In a pandemic, there are limits on what is preventable. In saying this, we're not denying the duty nor the importance of doing everything possible to protect both patients and staff, and NHS England worked hard to do this. We fully accept the importance of learning lessons on how to do things better, and looking back, we recognise that some harms could have been better mitigated with more attention paid to specific interests or issues. But it's still important not to judge what happened against unattainable ideals. Turning to structures for dealing with emergencies, the NHS is a complex system and it always will be. In an emergency, it needs clear direction. NHS England's EPRR structures were well established by 2020 and moving to level 4 offered clarity about the national response. NHS England believes that we were able to provide effective national coordination and support to local NHS organisations working alongside government but operationally focused. The inquiry has asked others within the 4 nations about whether they needed an NHS England and has heard varying responses. We don't say that one size fits all. We do suggest that within the ecosystem of the NHS in England, the oversight and coordination provided was an asset. We were able to do things quickly based on the information we'd gathered. The situation was highly stressful and right on the edge at times, but there was effective direction of the matters that lay within NHS England's control. Again, this is not to say that it was perfect, but our witnesses have sought to acknowledge and take ownership of those areas where there's a need for learning. The evidence that Ms. Pritchard gave about how, on reflection, NHS should have been explicitly clearer that guidance needed to apply to outsourced staff is one example of many. But in terms of lessons for the future, was our response delivered through the right structures? The National Incident Response Board, the cell system, regional teams? NHS England completely reorganised itself, creating over 200 COVID cells and work streams. These hearings have covered the work of perhaps 10% of them. Generally, our view is that our structures offered clear lines of accountability, rhythm, and an informed response. The UK-wide IPC cell has been the focus of much attention. The inquiry has heard of a lack of clarity on decision-making roles in a context in which UK HSA and national IPC leads all had a stake. There was no malintent here. If there were such failings, they derived from the desire to pitch in. To quote Sir Chris Whitty, "I don't think the people involved were exactly clear, although they were all trying to do their bit. This was not an abdication, an abrogation of responsibility." As UXA noted yesterday, there's now a written agreement between UXA, NHS England and the DHSC setting out their roles and responsibilities in relation to IPC guidance in England. So what more should be done to plan for such collaboration in advance? What are the peacetime changes to emergency response structures that should be made to address points of weakness, whether within the central EPRR structures or in relation to engagement with stakeholders? Do any of these translate into recommendations for change at the regional or national level? Turning to dilemmas, balances, risks, and the precautionary principle, and to more specific elements of our response, witnesses called have demonstrated the dilemmas that NHS England, with others, faced. The witnesses have equipped the inquiry in turn to think about the balances struck. You've heard debates about whether decision makers applied a precautionary principle, but also that the balance of risk is a more helpful framework. Sir Chris Whitty described it well when he said in oral evidence, "I think people have talked loosely of the precautionary principle. I consider it's only a useful principle where there are no downsides. Otherwise, you're talking about balance of risk, and balance of risk is a different concept." We specifically urge the inquiry to adopt the latter framework when considering lessons learned. We can't think of policy choices that have no downsides or additional precautions that do not come at a cost. But we would welcome the Chair's views on issues such as the balance of risk between the harm to staff from redeployment, staff overstretch, and at times overwhelm, set against the moral harm of its anticipated alternative, i.e. the routine or categorical denial of care. To avoid the risk of the latter happening, what option should first be exhausted? Second, at the risk of oversimplification, how do you balance the risk of more people becoming infected and dying against providing the best support and access to the individual receiving care? There was poignant testimony on the effects of a lack of physical access to patients or the absence of support from partners and carers. But we also know of concerns about visits and that these weren't unreasonable, given that there was likely to be a considerable risk of transmission from visitors at times of high community prevalence, to quote the inquiry's IPC experts. Again, how much engagement and consultation is realistic, not in general, but at specific points in time, when set against the need to move swiftly in a fast-moving emergency? Weight should be given to real-time learning. For example, the visiting guidance issued at the time of lockdown on the 25th of March 2020 was amended by the 9th of April to enable support for those with mental health issues. Then, what is the balance to be struck between setting a national standard against the value of local organisations being able to tailor solutions to local circumstances? Local NHS estates vary, for example. Can variations based on local needs genuinely be described as postcode lotteries? And if not, can we get better explaining them to people frustrated by inconsistencies? Should the principle of individual clinical decision-making remain paramount in a pandemic? We've heard discussion of decision-making tools to guide triage decisions. Some doctors sought them, but if deployed, such tools would have removed choice from doctors and provoked understandable resistance given the lack of public engagement. To avoid this, NHS England worked tirelessly to ensure that there was no need to apply systematic rationing guidance. Does Professor Powers's view that a national stakeholder debate should now occur represent a good way forward? The fourth point relates to fact-finding upon decisions taken. And when reaching conclusions, we would ask you to remember that decisions were taken at specific points in time with time-bound knowledge. We encourage you, first, to look at the daily SITREPs and data, including the modelling scenarios. As Ms Pritchard pointed out with regards to the Nightingales, this inquiry would be having a very different kind of conversation if those modelling scenarios had materialised, and we would have been unable to treat potentially many, many thousands of patients. Second, we encourage you to consider the resources actually available to NHS England or the NHS, and against that background to consider what the available counterfactual or alternative was that would have saved lives or served patients better. We've heard much about the adverse impact of decisions, but frequently less about available alternatives and their potential impact. There was much work done to make the best of resources in a highly imperfect situation, whether that was on supporting the distribution of limited PPE or using available PCR tests as best as possible. We also asked the inquiry not to forget what wasn't covered in oral hearings. We know that they are only a small part of the inquiry's work. We value the commitment to study all the written evidence, not least as some of the oral evidence has not accurately reflected the division of responsibilities between, for example, NHS England and the DHSC, on topics such as the sourcing and distribution of PPE, for example. We also suggest that, consistently with the terms of reference, the international context should be further explored to understand what others did differently and any lessons. For example, were the nosocomial rates in UK hospitals worse or better than others abroad? If now outside of the timeline for M3, the inquiry could still recommend that research is commissioned here and on other areas of uncertainty. For example, on the reasons why COVID-19 struck those with disabilities so very hard. Sir Chris Whitty noted the case for this. Finally, on the issue of recommendations. In thinking about lessons learnt, we need to ensure that we are not fighting the last war. We've described the pandemic as unprecedented, and it was. But the next one may be equally unprecedented or fundamentally different. It's important to have key elements of the response capability in place, including both a population and a health and social care service, which are as resilient as possible. And you've heard much about the need for greater resilience. But after that, it's likely that any response will depend much upon the ability to be flexible and agile. We have to acknowledge that any response will be imperfect and needs to adapt to uncertainties and choices around matters such as NPIs. Against that background, we commend to the inquiry both HSIB's and the House of Lords' work on recommendations. You will have seen the House of Lords report, Public Inquiries Enhancing Public Trust, and HSIB's Recommendations but No Actions report. There is a lot in HSIB's work about the challenges faced by the NHS in responding to many diverse recommendations. Equally, you've heard from Ms. Pritchard that the NHS is very much a system in recovery. We would urge the inquiry to make specific and achievable recommendations which take account of the steps or measures already in hand. My lady, we hope that these comments have been helpful and we look forward to your findings and recommendations.
Thank you very much, Ms. Gray, and they have indeed been very helpful. I'm very grateful to you.
Thank you.
Mr. Hyam is next, I think.
It is, thank you. Thank you, my lady. I make these submissions, these closing submissions, on behalf of the group of Welsh health bodies. The group comprises the majority of Welsh local health boards and a Welsh NHS trust situated in Wales, and collectively the boards and the trust were responsible for primary and hospital care for the majority of the population in Wales. Like NHS England, we would like to thank the inquiry for its productive and conscientious work, and those thanks extend, of course, to the inquiry and all of its various teams. At the conclusion of his oral evidence to the inquiry, Vaughan Getting, Minister for Health and Social Services in Wales until May 2021, was asked by counsel to the inquiry if he had one recommendation for how to improve the healthcare system's response in Wales. He said, "I think a lot of it is how you make sure the system is as collaborative and as open as possible so you can listen to the real experience of staff, and the challenge is how you manage that. But it's around culture in the service, and I think that really matters because you're asking staff to put themselves in harm's way, and how you listen to them and value them really does matter." A similar question about lessons learned was asked of the First Minister, Baroness Eluned Morgan. She said, "I think the NHS did remarkable work, and I think the staff on the front line did remarkable work, and there's a lesson there as well. To empower the frontline workers, I think, give them responsibility. We gave them responsibility, we empowered them with a lot of money. It's very difficult to do that in times of peace, but what they did was just incredible under the circumstances, and they acted really, really quickly. And you know, if we could bring some of that magic back now, it would be wonderful." The group of Welsh health bodies endorses those observations. They chime exactly with the sentiments and evidence expressed in writing and orally in the inquiry from members of the group, and were encapsulated in the oral and written evidence of Professor Philip Clure from the Spotlight Hospital in Wales, chosen by the inquiry, Glangwili General Hospital. Professor Clure too was asked a similar question at the close of his evidence by counsel to the inquiry, and in his two final suggestions pointed in particular to the staff survey of well-being, which was referred to a number of times by the inquiry's counsel. 2 points. Learning lessons, he said, "We've been very open about our report on staff well-being, the positives and the negatives, and I think many of the hospitals have undertaken similar work in learning what best supports staff well-being in these situations. Lastly," he said, "I'd say that really much earlier awareness of the impact on vulnerable groups, so learning what support we should be applying very early on in a pandemic to any vulnerable group, that would be important." Our overarching submission at the close of the oral evidence is that it was clear in Wales that members of the group were working within considerable constraints, in particular infrastructure and resources, but in fact performed remarkably well in those difficult circumstances, and have, through initiatives such as the transparent reporting of staff concerns, sought to learn the lessons of what worked and what did not work well in the pandemic, so as to better improve their services for the future. The general themes which emerged in both the initial written statements by the group and built on in oral evidence included the clarification that the main source of the guidance and advice given to the boards in Wales emanated from the Welsh Government, with whom there was and continues to be a good and close working relationship. The view of, for example, Joanne Whitehead at Betsy Cadwallader University Health Board was that the consultative and collaborative approach that was taken by the Welsh Government towards the health boards was effective and worked well. That sentiment is echoed in other written statements of the inquiry, such as that of Tracy Myhill, CEO at Swansea Bay, at the outset of the pandemic. She said, "My impression as Chief Executive was that the Swansea Bay University Health Board was more than able to keep the Welsh Government informed of developments within our organisation and in the community that we served." That evidence should, of course, be considered against the backdrop of the oral and written evidence given by Sir Frank Atherton, Chief Medical Officer for Wales, the general tenor of whose evidence was that the Welsh Government and local health boards worked well and cooperatively together in response to the very challenging circumstances the pandemic presented. Similarly, a notable feature of Dr. Andrew Goodall's evidence was that it was clear that Public Health Wales was in constant communication with the health boards and was not disabled from functioning from lack of data provided by them. The group would also noted from his oral evidence that Dr. Goodall thought that the response of the NHS staff in Wales was, his words, extraordinary. His view was that it was highly professional, committed, and that things worked best when the Welsh Government worked collaboratively with the local health boards and frontline staff. In the middle of all the various structures, it was, he said, important to recognise that the collaborative working that came out of the pandemic was a really good thing. Milady, the group of Welsh health bodies, agrees. The inquiry received evidence from Professor Philip Clure, who was Medical Director and Deputy Chief Executive Hywel Dda University Health Board at Glangwili during the pandemic. In addition to his witness statement, he gave oral evidence. The overall evidence which his evidence created was that the Glangwili Hospital had faced considerable challenges due to its infrastructure and capacity, but rose successfully to the complexities caused by the COVID-19 pandemic in a way that was caring, compassionate, and conscientious. To the great credit of Professor Clure and his hospital, it was clear that Glangwili Hospital had engaged with staff in an open and transparent way through staff surveys and other internal reviews, and he recognised that the staff have responded to the needs of our population in dealing with the pandemic and have gone above and beyond the call of duty at every opportunity. He said they have at times compromised their own health and well-being and home and family life to support our patients and colleagues and have worked to ensure that appropriate 24/7 care has been available to meet patient needs across our 3 counties. It was clear from Professor Clure's evidence that this proactive approach meant that Glangwili Hospital management were able to, and did, identify and understand specific concerns raised by staff and patients, for example, with respect to PPE and 2 reported matters relating to DNR orders. Professor Clure gave clear evidence of how the local health board was responsive to such concerns, and while he did not seek to diminish the lived experience of those who identified such issues, it was clear that there had been an entirely proper, balanced, and considered response to the concerns that were raised, whether it be vaccine rollout, lateral flow testing, or purposeful implementation of centralised IPC guidance to an ageing infrastructure. In terms of lessons learned and recommendations, the issues which Professor Clure identified in his witness statement and oral evidence are eminently sensible and based on his direct experience of working as a respiratory physician, but also as Deputy Chief Executive during the pandemic. It was clear that he'd worked tirelessly throughout this period and conscientiously sought to meet and to a large extent had successfully responded to the challenges that arose. The group note that many of the recommendations he identifies chime with the matters that other health boards have identified in their written evidence and include, and I provide this short list, that any future recommendations would need to look at the existing infrastructure of hospitals in parallel with future pandemic planning, that all modern hospitals should be designed with pandemics or serious infection outbreaks in mind, with existing buildings being upgraded, that pandemic planning needs to develop resilience in staffing, medical equipment and supplies, that there should be sufficient PPE stock, or at least local capacity to respond and supply such stock, built into the system. The development of reusable PPE would, he thought, change the landscape. That investment in accurate and up-to-date statistical modelling, taking into account the COVID experience, would be beneficial to all hospitals. The importance of national coordination of the senior clinical voice across Wales to ensure the rapid sharing of experience and learning, drawing on the experience of COVID to have pre-prepared guidance developed from the learned experience of COVID that could be rapidly adapted, to harness the learning from rapid development of vaccines to be applied to future pandemics, to share learning internationally on the best ways of maintaining the well-being of clinical professionals to a high-risk pandemic situation, and finally the development of surge capacity, whether through field hospitals or otherwise, should be decided nationally and funded centrally. In summary, the inquiry will already be aware from the statements from Ms Paget in her capacity as Chief Executive of NHS Wales that a considerable amount of work has already been carried out in Wales in terms of seeking to learn lessons from the COVID-19 pandemic, and much of that evidence is set out in Annex A to her second statement. This is all part of a firm commitment on behalf of all health bodies in Wales to seek to continue to improve the services they provide for the benefit of patients and in the wider public interest. Ms Paget was asked at the end of her evidence whether the patchwork of reviews which had been carried out had been sufficient. Her response was, and I quote, "I am confident that it has. I am confident that organisations have learnt individually what we are now going to be doing. We are now going to be reviewing all of the plans that NHS organisations have updated following their own learning lessons and reflections. We will review those both individually with organisations and collectively through the NHS executive. And if there are any further learning or lessons we need to address, then we will do so." My lady, much learning has already taken place. There is no question that to build resilience to a future pandemic, the hospital infrastructure and estate in Wales needs capital funding and upgrading, including improving ventilation systems and the like. Of course, one must be realistic as to the resources and capital funding available to the government in Wales for hospital improvements, but the group lives in hope. As observed, as Milady, you observed to Professor Clure at the end of his evidence, even institutions that start with Nissen huts can become like Heathrow. Thank you very much.
Thank you, Mr. Ham. I'm very grateful to you. Right, Mr. Stanton, BMA.
Thank you, Milady. The closing statement of the British Medical Association is as follows. The evidence heard during this module has reinforced the BMA's belief that while a pandemic or health emergency is always likely to put enormous strain on healthcare systems and the people who work within them, the severity of the impact was not inevitable. What is more, almost 5 years on from the start of the pandemic, the UK's health systems are in an even worse position to cope with day-to-day care, let alone an emergency. Waiting lists across the UK are around 9.4 million. There are severe staff shortages, bed numbers remain far too low, the UK's maintenance backlog sits at 17.3 billion, staff mental health and morale is in crisis, and population health and inequalities have worsened. Against this background, the task of your inquiry has never been more urgent and critical, and this statement highlights the key areas of evidence that the BMA asks you to take into account as you develop your report. It is in 4 main sections. First, the lack of capacity within the UK's healthcare systems. Second, the failure to protect healthcare workers from harm. Third, impacts on staff and patients. And fourth, recommendations. In respect of capacity, the inquiry's Module 1 report found that health and social care services were running close to, if not beyond, capacity in normal times. This lack of capacity includes insufficient numbers of staff and beds, as well as inadequate physical and digital infrastructure. And during the past 10 weeks of hearings, this inescapable reality has been reinforced by almost every witness, including the inquiry's experts, all 4 CMOs and CNOs, the heads of all 4 health services, and the political leaders of all 4 governments. It is vital that when the next emergency occurs, the UK's health systems start from a far more resilient baseline. In respect of staffing, when the pandemic began, the UK had a shortfall of around 40,000 doctors per capita compared to OECD averages. There were nearly 40,000 nursing vacancies in England alone, a shortage of around 2,000 midwives and obstetricians, 50% too few anaesthetists, a 10% critical care vacancy rate, and too few GPs to meet patient demand. In the words of a consultant from a BMA survey, what I needed most during the pandemic were the colleagues I was already missing. And to redress this shortfall will take time and significant investment because, as described by Professor Summers, you can't just magic up the staff you need. In addition, ageing estates meant that infection control measures could not always be fully implemented. Witnesses described working in unsuitable spaces with large open bays, an inability to distance between beds, a lack of side room capacity to isolate patients, and a lack of ventilation. In the words of Michael McBride, there is no doubt that the fabric of NHS estates increased the risk of nosocomial infections. Over 9,000 deaths are attributable to nosocomial infection in England alone, and we have heard many moving stories of those whose loved ones were admitted to hospital in circumstances unconnected to COVID-19, only to become infected and tragically die. Regarding the debate about whether the NHS was overwhelmed, the BMA points to the fact that vast swathes of care had to be cancelled and patients who would normally have received treatment did not. Healthcare workers were physically and emotionally overwhelmed, and they still bear the scars today. To downplay these impacts, intentionally or not, is a mistake. The BMA accepts that the decision to run the NHS in this way is a political one. However, the inquiry proceedings have laid bare its catastrophic consequences, which are destined to be repeated without fundamental change. Moving to the failure to protect staff from harm, witnesses, including Professor Sir Chris Whitty and Dr. Warren, have confirmed that healthcare workers were at higher risk of infection from COVID-19, and ONS data suggests that this increased risk was 6 times that of the general population. Despite this increased risk, the Health and Safety Executive abrogated its responsibility to protect staff by failing to challenge the adequacy of the IPC guidance, to act on concerns raised by organisations such as the BMA, and to ensure that employers complied with their health and safety responsibilities. The HSE's guidance on RIDOR, the reporting of injuries, diseases and dangerous occurrences regulations, inexplicably sought to discourage the reporting of infections by setting an unnecessarily high threshold for reporting. In the first 2 years of the pandemic, medical examiners found 357 cases of healthcare worker deaths from workplace exposure in England alone, compared to just 170 deaths reported through RIDOR in England, Wales and Scotland combined. Indeed, BMA analysis of ONS data found that the number of healthcare workers who died during the pandemic may be almost 5 times higher than the number reported through RIDOR. Accurate, detailed and transparent reporting is vital to understand the spread of infections, to ensure workplace safety, to facilitate access to compensation for staff with long COVID, and to recognise and pay tribute to healthcare workers who died while caring for others. And in this latter regard, the approach of the NHS during the pandemic is in stark contrast to the way in which other organisations, such as the Armed Forces, Police Force and Fire Service, honour those who die in service. In relation to PPE, some witnesses have stated that the UK never ran out of PPE and that the problems were with distribution. However, the BMA's position is that if a healthcare worker who needs PPE does not have it readily available and is thereby exposed to risk of serious injury, then this is a PPE shortage, regardless of whether the problem relates to distribution or stock quantity. The inquiry has heard shocking evidence about the lengths to which healthcare workers were forced to go to source PPE, including wearing makeshift items out of bin bags, ski masks, swimming goggles and cagoules, while others purchased equipment from DIY stores. In an example provided to the BMA by a GP in England, we had no PPE. Our first delivery was a box of 20 masks. This was for a surgery of 22,000 patients and 50+ staff. We made our own face shields with the use of a 3D printer loaned to us, and we made aprons from bin liners. In respect of respiratory protective equipment, such as FFP3, the inquiry has been provided with a very significant amount of information about airborne transmission, and the BMA will address this issue in detail within its written closing statement. For present purposes, the BMA simply restates its position in light of the evidence heard during the hearings and briefly responds to the points by those who argue against the wider use of FFP3. It was known prior to the pandemic that coronaviruses are transmissible through aerosols, not merely droplets, and that respiratory protective equipment, RPE, provides far greater protection against an airborne virus than a fluid-resistant surgical mask. Indeed, fluid-resistant surgical masks are not even classified as PPE. The recommended RPE for routine treatment of SARS-CoV-1 in 2013 was FFP3, and decision makers were aware from the very outset of the pandemic that SARS-CoV-2 could transmit via aerosol. In response to this risk from a deadly disease, a precautionary approach should have been taken through the recommended use of FFP3 for all staff caring for patients with or suspected to have COVID-19. Instead, FFP3 was restricted to just intensive care and to aerosol-generating procedures through a combination of concerns that intensive care might run out of FFP3, fears that staff might refuse to work if the recommended RPE was not available, and an over-reliance on droplet transmission. Worse, once the evidence in support of aerosol transmission became clear, the IPC cell stubbornly refused to change their approach, seemingly more worried about not wanting to look like they got it wrong, and advancing before this inquiry a series of after-the-event justifications, such as comfort and the need for further studies. The BMA has been astonished by the doubts expressed of the effectiveness of FFP3 respirators. As mentioned, there is clear evidence of their superiority, and witnesses, including inquiry experts, have provided evidence that those working in intensive care experienced lower levels of infection because of the enhanced protection available to them. Further, if the efficacy of FFP3 is seriously in doubt, why are they recommended for intensive care and aerosol-generating procedures? Attempts to justify the failure to recommend FFP3 based on considerations of comfort are equally surprising. PPE can be uncomfortable, but this is nothing balanced against the need to protect against a deadly disease transmitted by everyday actions such as coughing, sneezing, talking and breathing. These arguments are simply a continuation of the stubborn refusal to acknowledge the risks of aerosol transmission, to recognise they got it wrong and to take remedial action. In the words of a doctor in Scotland, the PPE guidance was based not on safety, but rather the lack of preparedness. False platitudes of staff safety were peddled out when in fact staff were left at higher risk. Staff confidence in the IPC guidance is essential for safety, and the widespread loss of confidence is a very serious concern. It is a matter of regret that the opportunity has not been taken to restore confidence by properly explaining the risks faced by staff and the extent to which supply shortages were a factor. Importantly, COVID-19 is still circulating today, and staff still do not have access to adequate RPE. The IPC guidance in all 4 nations continues to recommend a fluid-resistant surgical mask for routine care of COVID patients. And while in Scotland and Wales, staff can request RPE if they have concerns, in the BMA's view, this is not a sufficient guarantee of protection and is likely to exacerbate existing staff inequalities. This brings me to the third section, impacts on staff and patients. ONS data records over 860 COVID-related deaths of healthcare workers across the UK. But given there is no reliable system for recording this information, the true number is likely to be higher. In addition, many staff continue to be seriously impacted by long COVID, leaving them unable to work, train, and undertake day-to-day activities. Again, exact figures are not known, but the latest ONS data from March 2023 estimates this to be 4.4% of the workforce, which is in the region of 40,000 healthcare workers. The ongoing consequences of staff physical health were described by a secondary care doctor in England who told the BMA that, "My second COVID infection has left me with damage to my spinal cord. I now walk with crutches and cannot walk more than about 200 metres without them. I also have bladder and bowel problems and have to intermittently catheterise. There is not a day that goes by where I don't have some form of pain." Sadly, there are many more similar accounts, including the evidence of Nicola Ritchie of the Long COVID Physio Group and Dr. Natalie McDermott of CATA, both of whom developed long COVID after working without the necessary RPE and are now suffering debilitating consequences which prevents their return to full-time work. In addition to these serious impacts on physical health, powerful testimony from witnesses such as Professor Fong highlighted just how traumatic the last few years have been. Professor Fong described a member of staff telling him that it felt like a terrorist attack since this started, and we don't know when the attacks are going to stop. He also described in one hospital staff who were so overwhelmed that they were putting patients in body bags, lifting them from the bed, putting them on the floor, and putting another patient in their bed straight away because there wasn't time. Staff were far more exposed to death and critical illness than they had ever been before. In the words of a secondary care doctor working in Wales, "It was horrific. The patients were incredibly sick. There was a general feeling of being helpless. You'd do everything you could and they'd just suddenly die, and there was nothing you could do. Having to do end-of-life discussions over the phone, family members being unable to visit, it was bad, very bad." And because they were inadequately protected, staff feared for their lives and readied themselves for the possibility of death. They were terrified about passing infections to family members and went to extreme lengths to avoid this, including sleeping in their cars, changing clothes outside, and living in temporary accommodation. The sheer scale of the traumas experienced by staff is unprecedented. The inquiry's intensive care experts reported data from late 2020 that 50% of ICU staff met or exceeded the criteria for a mental health disorder. This points to a mental health crisis within the NHS, and it is a crisis that is continuing. A survey by NHS Charities Together from earlier this year found that over 3 in 4 NHS staff are currently struggling with their mental health. And 2 in 3 report that morale is the lowest they have ever experienced. Meanwhile, data from NHS England showed that over a quarter of all staff sickness days in 2023 were due to stress-related illnesses. Staff also suffered moral distress when capacity constraints meant that they were unable to deliver the care that they wished. Lack of capacity meant that staffing ratios had to be stretched to unsafe levels, patients could not be escalated to the next level of care, there were increased numbers of critical care transfers, and there were horrific difficulties accessing ambulances. These concerns about patient care were so severe that doctors raised them with the GMC. Finally, on impacts, infections and exposure were not experienced equally. The Health Service Journal estimates that over 60% of staff who died in the first month were from ethnic minority backgrounds. The gender bias within PPE design meant that female staff often struggled with poorly fitting PPE that left them at risk, while migrant and outsourced workers were disproportionately forced to work without adequate PPE. They were also more likely to be allocated to higher risk environments and were less able to voice their concerns. Lastly, recommendations. Before proposing a number of specific recommendations, we make two general observations about capacity and safety. It is the BMA's firm belief that any improvements in surge capacity will prove inadequate during a future emergency if health systems start from the same baseline as 2020. And we repeat that capacity is now worse, not better, than 5 years ago, which is a damning indictment. It is therefore vital for the inquiry to make recommendations that will ensure all healthcare systems have capacity for both day-to-day and emergency situations. As highlighted by Professor Sir Chris Whitty, the resourcing and configuration of the NHS is a choice and one that can be made differently. Regarding safety, there is an urgent need for improved protections for healthcare staff and patients in all settings. Any repeat of the experiences of COVID-19 is unthinkable, but again, this is exactly what will happen without urgent and fundamental change. Our closing written statement will set out proposed recommendations in more detail, but for now we highlight the following 9 areas. First, urgently update the IPC guidance across all 4 nations to reflect the evidence of aerosol transmission by recommending FFP3 for the routine care of patients with COVID-19. Second, require a precautionary approach in future emergencies to ensure maximum protection for healthcare staff and patients, with IPC guidance that is explicit about the risks and is updated when new evidence becomes available, backed by a stronger, more proactive health and safety executive. Third, ensure that pandemic preparations, including plans for rapidly scaling up the use of PPE across a range of settings, and a PPE stockpile that is suitable for a diverse range of face and body shapes. Fourth, we must invest to ensure healthcare systems are adequately resourced, including proper modelling of realistic workforce and bed stock needs. Fifth, we need to be able to scale up quickly when the next pandemic hits, which will require streamlined programmes to bring in additional staff more easily and flexibly. Sixth, NHS estates need to be significantly improved, starting with transparent and independently audited review of the condition of primary and secondary care estates and infrastructure, with urgent funding for the required improvements identified. Seventh, ensure that consistent and sustainable occupational and psychological support is available to all staff to improve their health at work. This will require strong direction and leadership from the top. Eighth, improve long COVID support services to ensure they are less variable, take a multidisciplinary approach, and that those suffering from long COVID receive proper support to return to work and proper compensation when this is not possible. Moreover, implement the recommendation from the Industrial Injuries Advisory Council to classify long COVID as an occupational disease. Ninth, address the culture of the NHS to ensure working experiences are less variable by background or protected characteristic, and that all feel able to raise concerns. Finally, the BMA appreciates that the inquiry's terms of reference require that your recommendations must relate to preparations for future pandemics. However, given that the severity of the impacts of COVID-19 stem from the underprepared and under-resourced health services, The BMA urges the inquiry to be bold in its recommendations and to address the fundamental issue of capacity head-on. Thank you, my lady.
Thank you very much, Mr. Stanton. I'm being challenged and being encouraged to be bold. I shall have to see how far I can go. Mr. John Charles.
Thank you, my lady, and good morning. This closing statement to Module 3 is on behalf of the National Pharmacy Association, the NPA. And my lady, may I say at the outset that the NPA, which represents the majority of independent community pharmacies in the UK, is most grateful for the continued opportunity to contribute to this module of the inquiry by this oral statement ahead of their intended closing written statement. The inquiry has heard evidence from two witnesses on behalf of the NPA, from Jonathan Rees, pharmacist and the superintendent pharmacist for two independent pharmacies based in the Swansea area, and from Nick Kay, current chair of the NPA, and who was vice chair during the pandemic. The inquiry has also published the written witness statement of Sanjeev Panisar, pharmacist and the superintendent pharmacist for a small group of independent pharmacies in the Birmingham area. These brief submissions, my lady, are intended to identify the principal issues which the MPA invites the inquiry to address and the conclusions it should reach in its Module 3 report. In particular, the impact of the pandemic on community pharmacies, given their key frontline role and the absence of recognition from government. In this connection, my lady, this statement addresses four key issues: the role of community pharmacy, including their place in the fabric of communities, the impact on pharmacy staff and their teams, the lack of recognition and the resilience of community pharmacy in the UK, and we also provide the MPA's suggested recommendations. May I begin then with the role of community pharmacy during the pandemic. Community pharmacy became the first port of call for patients seeking health advice during the pandemic. It has been described by NPA witnesses as the front door of the NHS and a shock absorber for the UK's healthcare systems. Community pharmacy is a crucial part of primary care in the UK. My lady, community pharmacies went to great and heroic lengths to ensure that their services were maintained during the pandemic and demonstrated the value of the network of community pharmacies across the country. The inquiry heard evidence of how community pharmacies stepped up in the crisis in so many different ways, from providing a safe space to support victims of domestic violence, to distributing lateral flow tests and maintaining a safe supply of medicines. There was huge and increased demand for their services as other parts of the NHS were required to limit availability. Community pharmacy was one of the few parts of the health service where patients could obtain expert health advice without an appointment. NPA members reported a significant increase in the number of prescriptions dispensed from February to March 2020, and phone calls to pharmacies more than tripled during this period. Home deliveries of medication to vulnerable patients more than doubled, requiring additional staffing and volunteers, and many pharmacies experienced long queues outside their doors. The inquiry has received evidence from the Pharmaceutical Services Negotiating Committee that the average pharmacy carried out 15 informal patient consultations per day. This is up to November 2020. And if pharmacies had not been available, this would have led to an additional 65 appointments in each GP practice each week in England. The increase in patient care spanned advice on minor ailments to much more complex and serious conditions requiring onward referral to other parts of the NHS. As Nick Kay put it in his evidence, this included someone saying that they had been coughing up blood for 3 weeks. The supply of medicines by community pharmacies to the local populations was challenging and complex. Many medicines became difficult to source and expensive as demand outstripped supply, and staff spent long hours sourcing medicines. On top of all of this, my lady, community pharmacy delivered some 40 million COVID-19 vaccinations. Finally, on their role, my lady, community pharmacies have a unique understanding of the health needs of the populations and the communities they serve. They are disproportionately located in areas of higher deprivation, delivering health services to communities that need them most. And they play a crucial role in reducing health inequalities. In his evidence, Nick Kay explained that approximately 50% of the NPA membership and 50% of the NPA board are from ethnic minority backgrounds. And he described how this level of diversity enabled the board to deliver effective policies, for example, in relation to vaccine hesitancy in the community and reducing health inequalities. Next, my lady, I turn to the impact on pharmacy staff and their teams. The increased demand on community pharmacy during the pandemic had a significant impact on pharmacists and their teams, resulting in stress, fatigue, mental health issues, and financial hardship for many NPA members. The evidence of Sanjeev Panisar provides some indication of the impact of the high workloads. He said, there was no real support from the NHS about how to best deal with the extremely high workloads we experience while simultaneously managing staffing shortages due to self-isolation requirements. For months, myself and some of the team repeatedly came in early before our normal opening time of 8:30 a.m. and stayed after our normal closing of 7 p.m. For example, starting early from 5 a.m. and staying until 11 p.m. midnight was a regular occurrence and continued throughout the pandemic into early 2022. We had to work such long hours in order to keep on top of workloads. The Royal Pharmaceutical Society's Workforce and Wellbeing Survey from 2022 showed particularly high burnout scores for those working in community pharmacy. Nick Kay attributed these scores to the uncertainty felt by the community pharmacists and their teams relating to, for example, how they would get the PPE they needed, how to get the medicines they needed, and how they would pay their teams. That becomes genuinely overwhelming, he said. Nick Kay described that one of the hardest things as chair of the MPA was listening to members asking, when is it going to get better, Nick? When's this going to change? And recognizing that members did not feel supported or an integral part of the healthcare system. Jonathan Rees highlighted the financial impact on pharmacies in light of the additional costs and expenses that were incurred during the pandemic, describing it as huge. Nick Kay told Inquiry that not only did members feel that they were an afterthought from government, but they were working from 7 o'clock in the morning until 11 o'clock at night, separated from family members for weeks on end and worrying about whether they could pay their teams and pay their mortgage. Mention of afterthought leads me to the third issue, that NPA members and their teams were overlooked, under-recognised or excluded. Community pharmacies and their teams were not treated equally with other frontline healthcare workers, and they did not receive the support that they needed. The most significant and demoralising example of this different treatment by government was the initial exclusion of pharmacy workers from the Life Assurance Scheme for frontline workers in England. The evidence of Matt Hancock during the inquiry hearings shed important light on this issue. He made clear that he had instructed that all pharmacy staff should be included within the scheme, but the system of government and the NHS failed to implement his clear direction. Mr. Hancock said, the pharmacy contract is managed by NHS England. In order to maximise taxpayer value for money, NHS England is by tradition really very tight on pharmacists. There's therefore inbuilt into NHS England senior management a lack of enthusiasm for giving more to community pharmacies than they absolutely have to. He went on to say, my sense was also that the system was not looking after community pharmacies enough. They evidently were an afterthought as far as the system was concerned. Another example of the sidelining of community pharmacy was the initial lack of PPE through the NHS, requiring many pharmacy teams to source and fund their own PPE. Pharmacists were unable to access the NHS PPE portal to order PPE until August 2020, some months into the pandemic. The supply of PPE was a challenge, and pharmacy teams put themselves at risk to help patients stay well, often working in close proximity to others and reusing PPE repeatedly for days or even weeks. Again, in his evidence to the inquiry, Mr. Hancock confirmed that he had pushed for community pharmacists to have access to the PPE portal. And he said that in times of constrained supply, community pharmacists, rightly or wrongly, were deemed to be lower in the priority for people that needed access to the PPE portal. My lady, it was also the case at the start of the pandemic that many people who worked in community pharmacy were not recognised as key workers, which would allow their children to attend school while they worked, notwithstanding that they were working in a frontline healthcare environment. Nor was COVID-19 testing initially available for community pharmacy staff. And community pharmacy was initially categorised as a retail setting, as opposed to a healthcare establishment, which meant that entire pharmacy teams needed to self-isolate following a single positive case within the pharmacy. This resulted in fewer available staff and increased pressure on remaining pharmacists and pharmacy teams. Having regard to the clear failure to properly recognise community pharmacy as an integral part of NHS primary care, the MPA's participation in this module has provided some solace to MPA members in allowing the voice of community pharmacy to be heard and the significant impact of the pandemic on this sector to be recognised. The fourth principal issue, my lady, is lack of resilience and funding issues. Community pharmacy entered the pandemic facing financial and workforce crisis due to long-term underinvestment in the network. These issues presented significant challenges for community pharmacy in responding to the pandemic and increased the difficulties in providing services to patients and maintaining staffing levels. My lady, since the start of the pandemic, approximately 1,000 pharmacies have closed in England. 1,000. The healthcare system is less resilient to respond to a future pandemic than at the beginning of 2020. Unless urgent action is taken to redress the situation, the vital services that community pharmacy provide, which play such an important role in the pandemic response, will not be available to the same extent in a future healthcare crisis. When turning to the future and recommendations, and with regard to the recommendations, may I draw attention to and build upon Nick Kay's 3 simple asks at the end of his evidence to the inquiry, to better enable pharmacists to fulfil their critical role in a future pandemic. His 3 key asks were to make sure that we're here, use us, and we are part of primary care. So 3 broad asks: make sure that we're here. An accessible pharmacy network adds to the resilience of the health service, reduces health inequalities, and must be maintained. If pharmacies continue to close at their current rate, the UK will not be able to respond adequately in the next pandemic. Use us. The MPA invites the inquiry to recommend that the full potential of community pharmacy is recognised and utilised to support other parts of primary care. In any future pandemic, additional services should be built around existing infrastructure wherever possible. We are part of primary care. That community pharmacy is part of primary care alongside general practice, optical services, and dentistry ought to go without saying. However, as Nick Kay indicated in his evidence, a cultural shift from government is necessary to fully recognise that community pharmacy and their teams are genuinely part of the NHS family. Government and the NHS should recast community pharmacy in their minds as a valuable partner in the post-pandemic recovery, not as a cost centre. My lady, given the essential nature of their frontline role, the inquiry is asked to recommend that there is sufficient investment by government in the network and the infrastructure needed to integrate community pharmacy into the broader health system and to support effective cooperation across the health service. My lady, the final ask concerns recognition of the role of community pharmacy during the pandemic. The MPA asks that the significant contribution of community pharmacy to the pandemic response is reflected in the Module 3 findings in order to redress the lack of recognition they received throughout the pandemic. That concludes our oral statement, my lady.
I'm very grateful, Mr. John Charles. Thank you very much. Ms. Domingo, could you take us up to the break, please?
Thank you, my lady. My lady, this is the oral statement on behalf of the Royal Pharmaceutical Society. The inquiry has heard evidence during this module of the essential work of pharmacists, pharmaceutical scientists, pharmacy technicians, and wider pharmacy teams in supporting the nation's health. Last week, however, we heard from the former Secretary of State for Health and Social Care, giving a brutally honest account that the system was not looking after community pharmacists enough. This relegation of a central element of primary care to an afterthought and a lower priority than other parts of the healthcare system is a very significant concern that explains much of the unfair treatment of community pharmacy throughout the pandemic. And it is one of 4 key issues that this statement seeks to highlight. The other 3 are, first, the failure to keep pharmacists and pharmacy teams safe while at work. Secondly, the impact of the pandemic on their health and well-being. And finally, the resilience of the community pharmacy sector more broadly. But before addressing these issues, the RPS wishes to raise the work of hospital pharmacists, which is often less visible and is a perspective that the inquiry has not heard in these hearings. Over the period of the pandemic, hospital or clinical pharmacists provided expert knowledge in the usage and administration of medicines, caring for the most critically ill patients with COVID-19, transforming their services and ways of working, and supporting the supply of medicines for critical care. The inquiry's experts in intensive care medicine have told the inquiry that ICU specialist pharmacists and pharmacy technicians were critical to the pandemic response in sourcing alternative medicines and minimizing the impact of the medicines shortage on the provision of clinical care. The inquiry has received a statement from Josh Miller, a clinical pharmacist working in the acute sector of a large health board in Scotland and a board member of the RPS. He has told the inquiry of the challenges facing hospital pharmacists and the impact on patient care during the pandemic. These included responsibility as a pharmacist for up to 4 respiratory and acute wards and 120 patients per day. Each ward consisted of 30 beds containing 4 bays of 6 beds each and just 6 single-bedded side rooms for the isolation of infected patients. Side rooms became quickly overwhelmed as the virus spread to the patients within the bays, and as the wards became closed off, access to patients to discuss their medicines was restricted. Mr. Miller described communicating with patients by mobile phone rather than face-to-face to discuss their medicines, which severely limited the ability to adequately counsel patients. Mr. Miller was fit-tested for an FFP2 respirator as he was working on acute wards, and he describes the lack of respirator availability that required healthcare workers to be fit-tested with alternative types of masks. He also described how pharmacy teams within hospitals were often responsible for oxygen supplies and the real concerns about oxygen shortages to support ventilators. The pharmacy team was on call out of hours to move and handle oxygen cylinders, which was physically demanding and risky work, for which no risk assessment was ever undertaken. Safety at work for pharmacists is a key concern for the RPS. The RPS witness statement stressed the importance of protecting pharmacists and pharmacy teams including through appropriate use of risk assessments, ensuring infection prevention and control guidance was suitable for all healthcare settings, including pharmacies, and the provision of adequate and effective PPE to pharmacists and their teams. The inquiry has heard evidence, including from MPA Chair and RPS Fellow Nick Kay, that pharmacists and wider pharmacy teams went above and beyond during the pandemic, often putting themselves at risk so they could continue supporting patient care in a time of national crisis. In the early weeks of the pandemic, many members of the public presented to their pharmacy even when showing symptoms of COVID-19. As Nick Kay told the inquiry, they were trying to seek help and didn't know where else to go. However, by providing face-to-face care to patients, the pharmacy teams were putting themselves at risk of infection. Pharmacy spaces by their nature are generally small, making it difficult, if not impossible, for pharmacy teams to maintain safe social distancing while at work. An RPS survey undertaken in April 2020 showed that 94% of respondents said they were unable to maintain 2 meters social distancing from other staff in their workplace, and 40% were unable to maintain social distancing from patients. The inquiry has heard evidence that the majority of frontline pharmacy teams struggle to source PPE to protect themselves, their patients, and their families, resorting to buying their own PPE, including from local DIY centres, or relying on local schools providing masks. This meant that pharmacists and their staff risked spreading the virus or being unable to work because of sickness. Despite being an essential part of primary care, community pharmacy teams were only able to access the government's PPE portal from the 3rd of August 2020, after the first wave of the pandemic. Even then, the inquiry has heard evidence that initial supplies were quite strained, and it wasn't until around November 2020 that pharmacies could increase the amount of PPE they could order. The RPS England chair commented in May 2020, "Pharmacies are one of the last places keeping their doors open to the public without an appointment, and yet seemingly an afterthought when it comes to sourcing PPE for staff." This sentiment that community pharmacy teams were an afterthought was substantiated by the evidence of the former Health Secretary that in times of constrained supply, community pharmacists were deemed to be lower in the priority for people that needed to access PPE. The safety of all healthcare workers attending their work to care for patients during the pandemic should have been a priority for government, but it is apparent that this was not the case. It is the RPS's position that frontline staff should have the same support across the whole of primary care. The pandemic had a significant impact on the health and well-being of pharmacists. The inquiry has heard compelling evidence about the enormous strain of the pandemic on pharmacy staff and the dedication and determination of pharmacists to keep looking after patients in the face of unprecedented challenges. Workload doubling for weeks and months, phone lines constantly in use from patient queries, working overtime every day, increases in the number of prescriptions, increases in the number of deliveries to shielding and vulnerable patients, and hours spent sourcing medicines that were in short supply. This huge surge in demand stretched the personal and professional resilience of pharmacists and their teams. Responding to a call for evidence, one RPS member in Wales described, "There was a massive impact on mental health, increased pressure of workload, medicines shortages, and trying to keep your family safe." Other stresses came from financial worries, and Nick Kay told the inquiry that people want to do the right thing and give the care to the communities they service, but being able to pay their bills is another pressure. The RPS's workforce survey results show that burnout scores for the community pharmacy sector have been consistently high since 2020, with 88% of respondents to the 2022 survey reporting they are at high risk of burnout. Pharmacists continue to warn about rising pressures at work and the impact on their mental health and well-being. This continued risk of burnout is evidenced by the responses of more than 6,000 pharmacists and pharmacy technicians to the RPS's latest workforce wellbeing survey this month, a report that will be published in the spring. The systemic difference in treatment between pharmacists who provided NHS contracted services compared with healthcare workers directly employed by the NHS has also contributed to pharmacy workers feeling demoralised and frustrated. The disparity in treatment was seen in the exclusion of pharmacists from visa extensions provided to other healthcare workers in March 2020, in the absence of specific mention of pharmacists in guidance regarding key workers, which impacted childcare provision at school hubs, and significantly in the initial exclusion of community pharmacists from the life assurance scheme covering frontline health and care workers in England. The inquiry has heard evidence that inbuilt into the system and into NHS England senior management was a lack of enthusiasm for giving more to community pharmacy than they absolutely had to. This was despite pharmacists' crucial role in providing care throughout the pandemic, which undoubtedly alleviated pressures on other parts of the NHS, and which placed pharmacists at heightened risk of coming into contact with COVID-positive patients. Pharmacists and pharmacy teams working across the health service played a key role in the success of the COVID-19 vaccination campaign, with 71% of all COVID vaccinations delivered through general practice and community pharmacy. Given their fundamental role in helping to get the country and the economy back on its feet, the failure to provide community pharmacists with equal levels of support and protection must not be repeated. COVID-19 showed that community pharmacies are an essential provider of primary care, and the RPS strongly supports the call to reframe community pharmacy, pharmacists and their teams as a genuine part of the NHS family. Finally, the resilience of pharmacy services is a significant concern. We continue to hear about the pressures facing community pharmacies, and the recent independent investigation of the NHS in England, led by Lord Darcy, noted concerns about pharmacy closures, reduced patient access to care, and the impact on health inequalities. The pandemic also exposed the complexity and fragility of medicine supply chains, leading to shortages of many commonly used medications as well as those used in critical care. The resilience of frontline workers and workforce capacity must be considered in preparation for a future pandemic, with adequate support for pharmacy services across all care settings and steps taken to strengthen the medicine supply chain and medicines production. A new report from the RPS, which was published yesterday, the 26th of November, and developed in discussion with patient groups, health professionals and wider stakeholders, examines the growing impact of medicines shortages on patient care. It calls for a cohesive cross-government and NHS strategy across the UK to improve medicines access, with actions to build supply chain resilience, support UK manufacturing, improve data connectivity, protect access to life-critical medicines, and reduce duplication across the NHS. With some national governments looking to develop long-term NHS plans, the RPS submits that the lessons learned from the pandemic must include longer-term reforms to better manage demand and build resilience across the health service. Pharmacists and their teams will continue to play a key role in our health service and will be essential in the event of a future public health emergency. Thank you, my lady.
Thank you very much indeed, Mr. Mingo. Very grateful. Very well. I shall break now and return at 25 to 12.
morning, my lady.
So I didn't catch the first bit, Ms Neal, sorry.
I
Did you
just
say-
said good morning, my lady. I was just checking that you're able to hear from the hearing room.
I can, thank you. I think the next speaker is Miss Campbell, isn't it? Miss Campbell?
Thank you, my lady. When you think back over the evidence you have heard in this module, I dare to suggest that the evidence of a number of witnesses will stand out. To mention but a few, the evidence of John Sullivan, from whom you first heard, will live long in our memories. His devotion to his daughter on vivid display throughout his evidence. He told us about Susan, who needed him and his wife as her voice throughout her life, and never more so than when she was taken into hospital during the pandemic. But the doors were closed on them. His efforts to be recognised on Susan's behalf as her advocate, her care partner, went unmet, up to and including that decision not to admit Susan to critical care because it seems, of her disability. The evidence of Dr. Sarah Powell, who amongst her many accomplishments is a truly excellent communicator. She told us so powerfully about the persistent failure to consider the needs of the disabled and the combined failure to recognise and to treat long COVID. For too long, too many with the power to make changes were deaf to her experiences. The articulate and constructive evidence of Julia Jones of John's campaign, who epitomised so clearly the need to imbue protective measures with compassion and common sense. She gave powerful evidence of the legacy of grief, guilt, anger and mistrust that is left behind when people are left to die alone because guidance was allowed to trump the most basic human right to dignity and to the comfort of a loved one in death. She urged you, as did so many others, if you can make just one change, change that. The evidence of Professor Beggs, your expert witness, and I dare say one of the best expert witnesses from whom you have heard throughout your inquiry so far, largely because of his ability to convey complex issues of physics in clear, comprehensive and evidence-based terms. It was a remarkable feature of his evidence that to all of us who heard it, some for the first time, it made perfect sense. And in our mind's eye, we can all clearly see Professor Fong, who bore vivid witness to the sheer horror of what was being experienced by too many patients and too many healthcare staff on too many wards in too many hospitals. My lady, you have heard all that and much more, a combination of powerful evidence about what went wrong in the healthcare response to the pandemic, interlaced with evidence of heroism of many frontline healthcare staff who kept turning up despite the risks they were exposed to day in and day out. You have also seen evidence of the indefatigable determination of individuals and groups not to be silenced, to force learning where there was ignorance, and to force change in the face of denial or inertia. It is, my lady, a mark of accomplishment of this module that the most powerful evidence that you have heard has been from individuals or groups who were not listened to during the pandemic, and in many cases since. Whether the issue was racism or long COVID or disability or the clinically vulnerable or pregnancy and childbirth, or errors in IPC understanding and guidance, or death and bereavement, those impact witnesses all have one thing in common. They were not listened to. They were sidelined, disempowered, silenced, and ignored. For many, right up until they took their place in your witness box, not for the want of trying, they could not get their voices heard. They could not get in the room. It seems, in fact, that some are still not being heard. How could anyone listen to the evidence of Professor Fong and continue to maintain that the NHS was not overwhelmed during the pandemic, when the evidence of the horror of what he and others witnessed in hospital did not even take into account the suffering of hundreds of thousands who could not access medical care because their screening or their treatment was delayed or cancelled. And yet that was the position of Matt Hancock and other health ministers from across the UK, even when challenged by you. By contrast, my lady, you have listened. And even when unwell, you are still determined to listen. And now the burden on you to transfer the combined experiences of the witnesses into meaningful recommendations for the future is significant. I hope it is not too presumptuous to predict that one of your recommendations will be in relation to communication. But if that communication only comes from the top down, we will have achieved nothing. Because the essence of good communication is the ability to listen and to try to understand what it is you are being asked to change and why. And there has been little evidence of listening, even to the evidence from this very hearing room. You observed at the end of Ms Ferguson's evidence yesterday that the only way that your recommendations get implemented is if groups like the Northern Ireland COVID bereaved families keep the pressure up. That is undoubtedly true. But given the strength of the evidence that we have heard, it's undeniably sad. It should not be for the bereaved or the disabled or migrant workers to continue to force change. As you heard yesterday, democracy really is everyone's responsibility, including those who are voted into power to lead a democracy or who are employed to lead organisations of the state. It has not gone unnoticed by the bereaved that there has been a distinctly lopsided presence in your hearing room. That following questions from counsel to the inquiry, so many witnesses risked leaving the witness box with a crick in their neck as they turned to answer questions from the non-state core participants who in the main sit to your right. What lessons have been learned, we repeatedly asked. What can be done better? We wanted to know. All the while reduced to the hope that those who can implement the lessons learned or who have the ability to do things better in future or the power to implement the recommendations that you will make had at least one ear to the live stream or would cast an eye over the transcript. Because, my lady, often they weren't in the room. On behalf of the Department of Health Northern Ireland, we were assured only yesterday that the department had indeed listened carefully to and reflected on all the evidence that had been heard. That listening, it was then revealed, had led the department to conclude that the evidence was in part wrong, or had been misunderstood, or required to be refuted. Descending into an unedifying game, but a familiar game of Northern Ireland finger-pointing between the department and the Public Health Agency as to who knew what or should have known what. Mr. Dawson, we were told, doesn't understand what data was available, perhaps because he's only been in post since early 2021. It seems, my lady, that it's the position of the Department of Health that the Chief Executive of the PHA, who has been in post for almost 4 years, since the middle of the pandemic, doesn't yet understand what data was available to his agency and from where it came. It beggars belief. You were asked by the department to simply accept that the long-standing and enduring concerns about inappropriate use of DNA CPR. I'm so sorry, my lady. My lady, would you just give me one moment, please? I'm afraid I've had a technical misfunction.
You were just completing Mr. Dawson and data?
Yes, I'm so sorry. This is the danger of not having a printout. You were asked to simply accept that the long-standing and enduring concern about the inappropriate use of DNA CPR are entirely misplaced because the department never had a policy that permitted the increase in their use during the pandemic. You should rest assured, it seems, that there is nothing to see here. It was asserted that the military assessment team had got it wrong when, having been invited by the Department of Health to give their assistance and expertise, they raised concerns about a lack of central control. Even, it seems, Mr. Scott got it wrong when he tested the former Minister of Health's evidence in relation to the location of the Nightingale Hospital. And you, my lady, need not worry, because the gaps in data identified by witness after witness are about to be solved by a 10-year rollout of a new electronic system that, as yet, is only 60% implemented. My lady, I had intended to list the areas in which we learned there are gaps in data in Northern Ireland, but the list is too long and my time is too short. We will return to it in writing. If the department had really listened, not defensively, but with a willingness to learn, the evidence they would have heard included that Catherine Todd was not listened to when, having contracted COVID in summer 2021, she repeatedly contacted primary health care convinced that all was not well with her baby. That she was denied a potentially life-saving scan because, according to her records, she was 27 weeks and 6 days pregnant, and the scan was only available from 28 weeks the very next day. That there was no sense and a great deal of hurt in the manner in which Miss Todd and her partner TJ had to witness their baby die, and in their treatment after his death. And that such is the state of the healthcare system in Northern Ireland, that as a pregnant woman in Northern Ireland in 2024, she did not feel safe. If the department had really listened, it might have acknowledged that families in Northern Ireland have been raising concerns about the improper application of DNA CPR notices since the outset of the pandemic, and that, as Mr. Swan accepted in his evidence, there remains an opportunity retrospectively to consider and reflect on the true picture of this critically important issue. Instead, the department retreated to its position that there was no policy and nothing to see. It is no answer to the concerns of the bereaved that, as Mr. Swan seemed to claim, he took it from his officials or the chief nursing officer that the improper use of DNA CPR wasn't happening, choosing, it seems, not to listen to the concerns of those who were independently and collectively telling him that they knew different. If the department had really listened, it might have offered you assurances that it had heard the harrowing evidence of the impact of visiting restrictions, particularly at the start of life or for dementia patients or those nearing the end of life. It might have reflected on Mr. Dawson's evidence of a 9-month process in 2021, discussions in January, a paper in June, a letter in September to facilitate testing for hospital visitors. It might have acknowledged that that delay was inhumane and unacceptable and is never to be repeated. If the department had really listened, it might have responded to the witness statement of Fidelma Mallon, whose husband was admitted to hospital for an operation and acquired COVID in that hospital setting. It would have acknowledged the inconsistency in the fact that in a neighbouring trust he would have been treated at home prior to admission for an operation. And it might have offered some assurance as to how inconsistent approaches between trusts were being addressed. If it had really listened, the department might have acknowledged that providing a nurse with an email address to report gaps in PPE is no substitute for a system that manages and controls and provides stocks of appropriate PPE to the front line from the outset. It might have addressed the plans to reform outdated hospitals with cramped wards, ventilation limited to opening windows, and poor oxygen supply. If it had really listened, the department might have acknowledged that people like Martina Ferguson were bringing these issues and more directly to its attention from the outset, and its failure to act and respond in a consistent and compassionate way left people like Miss Ferguson, like Ms. Doherty, Katrina Daly or Lauren Mallon, who sit behind me, and many others who watch from home, with a choice of not comforting their loved ones in their final moments or fighting their way onto wards to be with their dying relatives, positions that never the patient, nor their loved one, nor the nurse on duty should ever have been in. There was not a word of reflection from the department in relation to the evidence of airborne transmission and the scientific divide over droplet size or aerosols, notwithstanding Mr Swan's evidence that he was aware of the debate from May 2020 and Sir Michael McBride's evidence that he simply accepted and adopted the position of his colleagues in England. Those generating that debate, Professor Beggs and Dr Jones, appeared to be categorised by Sir Chris Whitty in his evidence to you as, quote, outliers. Others will, I know, address this in greater detail. But those who challenge the prevailing approach with solid, evidence-based, well-researched and scientifically recognised input must not be relegated to the margins. They must be listened to. Politicians and their advisers must be willing to adapt, to change course when evidence becomes available, that it is necessary to do so, recognising that the cost of changing course or admitting some errors is never to be traded against the cost of lives lost if you don't. It is important to emphasise that this inquiry is not about apportioning blame. Self-evidently, this was an entirely novel and unprecedented virus. We recognise that people were striving to do their best, even if retrospectively it is apparent that things could be done better. But at this point, post-pandemic, more than anything, there must be evidence of reflection and work towards meaningful change. And yet the absence of reflection, of lessons learned in the evidence from Northern Ireland is stark. It was stark in the statement of the Public Health Agency. It was repeated in the statement of Mr Swan, and my lady, it appears to persist. And the truth is, my lady, and I mean no discourtesy whatsoever to you or your team when I say this, that there is a limit to which this module can help us. The issues in the Northern Ireland healthcare system are too large, pervasive and systemic, and the time available and the scope of this module was necessarily limited. Who can forget the statistic accepted by the CMO in his evidence as, quote, roughly accurate, that pre-COVID waiting time figures for a first outpatient appointment to start a pathway to treatment were 2,000 times worse in Northern Ireland than a comparable figure in England. The reality is that the waiting time statistics quoted by Mr Wilcock King Counsel in his opening to you back in September realistically will only have extended over the 12 weeks since. It's a sobering reality that as we approach the 5-year anniversary of the onset of the pandemic, little has changed in Northern Ireland. Has anything changed for the hundreds of thousands trying to access a treatment pathway, or for pregnant women? Is the future brighter for long COVID sufferers? And importantly, if a pandemic hit tomorrow, would the outcome for the bereaved be any different? You know, my lady, that we hold our deceased relatives in a special place in Northern Ireland. The Northern Irish COVID bereaved are unwavering in their commitment to ensuring that the posthumous legacy of those we have lost is a brighter future for those who are still here. But they cannot achieve that alone. And my lady, not for the want of trying, you cannot achieve that from Paddington. The solution has got to be homemade. So once again, my lady, the call goes out to those in leadership in Northern Ireland to commit to working with the bereaved and with all affected to ensure lasting change. Thank you.
Thank you very much indeed, Ms Campbell. As powerful as I expected. Thank you. Mr Jacobs.
Good morning, my lady. These are the submissions of the Trades Union Congress. I'm instructed by Thompson Solicitors and appear with Miss Ruby Peacock. Much of the evidence in this module as to the impact of the pandemic upon healthcare workers has been troubling yet unsurprising. It is well understood that the UK's healthcare services were and are stretched in terms of staffing and resource, that the pandemic struck at a time when staff were already overworked, and that the workforce suffered terrible loss, trauma, burnout and moral injury. It has, however, been essential to hear workers explain the experience of working through the pandemic. It has brought weight and depth to the written words in witness statements. Understanding and recording that impact is in part to acknowledge it, which is important. It serves to inform both the content of and priority for recommendations. But it also plays a crucial role in making clear the importance of non-pharmaceutical interventions. Refraining from the more stringent interventions in the next pandemic would not only risk avoidable loss of life, it would be to abandon the over 2 million workers in the 4 nations' healthcare services. That is a simple but vital lesson of this module, which should be made clear in the inquiry's report. These submissions, however, focus predominantly on the question of recommendations. In these oral submissions, we address you on disproportionate impacts and structural racism, the state of the UK's public healthcare services, dynamic staffing capacity, precarious work, regulatory response, and vaccination as a condition of deployment. Our written submissions will additionally cover infection prevention and control, data on the impacts of COVID-19 upon healthcare workers, risk assessments, and social partnership. First, my lady, the disproportionate impacts upon Black, Asian, and minority ethnic healthcare workers. To our clients, the evidence on this topic has been disheartening. The unequal impact revealed so early in the pandemic with deaths of Black, Asian, and minority ethnic workers was well known before the module started. The burning questions were why and what needs to be done. Pre-existing inequalities in society are obviously relevant. However, systemic discrimination within the healthcare service is certainly part of the problem. It exists in plain sight and in the stark figures produced in recent years. NHS England's 2023 Workforce Race Equality Standard reports that representation of Black, Asian and minority ethnic staff drops off sharply above pay band 5, and that amongst nurses, midwives and nursing assistants, the largest part of the NHS workforce, BME staff and staff from other white backgrounds have poorer experiences of working for the NHS than their white British colleagues. This inequality, it says, is most marked for Black staff who feel the least equality of opportunity and are most likely to be victims of discrimination. Similar statistics arise out of the Workforce Race Equality Standard for Wales, which is reported for the first time this year. The figures chime with the first-hand evidence gathered by the inquiry of minority ethnic staff, feeling unable to raise concerns for fear of being disciplined or erased from the register, having poorer access to risk assessments, fit testing and PPE, and being disproportionately deployed to frontline high-risk roles. Professor Whitty suggested that the pandemic was a wake-up call, as if one were needed, he said, that these problems exist within the health service. But has it been a wake-up call? The answer, we say, is unfortunately no. It is striking that 2 consecutive health secretaries, Mr. Hancock and Sir Sajid, have both in their evidence espoused a policy of colour blindness, the idea that as long as everyone is treated the same, the disproportionate impacts of an action, policy or system do not matter. The idea that a policy's blindness to disproportionate impact is either a means to addressing it or even an excuse for its disproportionate impact is a facile approach. Public authorities are under a duty to take steps to advance equality of opportunity, which may include removing or reducing the disadvantage faced by persons with protected characteristics or taking steps to meet the specific needs of people with those characteristics. It appears that at a ministerial level, there was a fundamental misunderstanding of this duty owed to Black, Asian and minority ethnic workers in healthcare and of what practically is required to eliminate systemic barriers. We have seen many witnesses anxious to state how serious the problem is. What has been lacking is not only answers, but actually a lack of any real sense that there has been sustained determined and ongoing effort at removing the barriers. The inquiry has quite properly pressed for detail as to the actions which need to be taken, but answers have, on many occasions, been hesitant and devoid of substance. NHS England has assisted this module with 4 corporate statements which extend over 1,300 pages of evidence. Those 1,300 pages say very little about the issue of systemic racism within the health service. For the wake-up call to land, the report of this module is a crucial opportunity. Many of the general recommendations developed through this submission are designed to ameliorate disproportionate impacts, and we will come on to those shortly, but that is not enough. There is a need for recommendations which fundamentally prompt a shift from a practice of recording systemic racism to actually removing it. In our written submissions, they will include as follows. First, a need to remedy the problem of NHS England abrogating too much responsibility to the trusts as the employers. NHS England needs to take a leadership role to promote change and shared learning across the NHS. It should review current policies and bodies responsible for its race equality work. Consideration should be given to whether an equivalent to the Anti-Racist Action Plan in Wales ought to be introduced in England. Second, there is a need for accountability for change on these issues or lack of it. Trusts should be required to report progress on the NHS England Equality, Diversity and Inclusion Plan, which should be independently evaluated so as to create accountability. Third, the NHS England Equality, Diversity and Inclusion Plan and the NHS Wales Anti-Racist Action Plan should extend to the indirect workforce. We will develop these further in our written submission alongside other recommendations relating to the NHS Race and Health Observatory, the role of equality, diversity and inclusion leads in trusts, and the publication and effectiveness of equality impact assessments. We turn to the state and capacity of the UK's public healthcare systems. At the very heart of the evidence in this module has been the poor state of the UK's healthcare systems going into the pandemic. That extends to its physical estate, equipment, and crucially, its staffing. In response to questions, Matt Hancock was quite dismissive of the notion that recommendations on healthcare capacity cross a Rubicon into the political realm out of reach of a public inquiry. Whatever one thinks of an admonishment from Matt Hancock, maybe he had a point. Sir Sajid was not dissimilar in urging ambition upon the inquiry. Whether to accept a recommendation is undoubtedly a political decision, but it is the duty of the inquiry to make recommendations where they are necessary. The confines upon the inquiry are not set by its instincts on what becomes too political, but by the inquiry's terms of reference. My lady, your terms of reference require you to consider, to quote from them, initial capacity and the ability to increase capacity and resilience, and also to identify the lessons to be learned. It is the inquiry's duty to fulfil those terms of reference. The inquiry is required to examine questions of capacity and to learn the lessons. In fact, recommendations that steer clear of this issue risk being counterproductive. They would give a false impression that resolving some of the narrower issues can surmount the fundamental problems of capacity and staffing. The reality is they cannot. In respect of staffing shortages, the emphasis must be upon increasing standing capacity, resilience and flexibility within the substantive workforce. Any mechanisms to supplement that workforce in a pandemic, such as use of volunteers or the military, partnerships with the private sector or a reserve workforce, must be very much secondary to a focus upon reducing existing vacancies, ensuring enough staff are presently trained and recruited to meet future need, and retaining existing staff. Clearly, it's a problem that can only be resolved with long-term action. The National Audit Office's modelling suggests that the NHS England presently has a workforce shortfall of 150,000 full-time equivalent staff, a vacancy rate of almost 10%. NHS England itself projects a shortfall of over 250,000 staff by 2036. NHS England's long-term workforce plan is an important step in the right direction, but the TUC has concerns, to be expanded in our written submissions, that the plan lacks the potency required to really tackle a crisis of this scale. As of June 2024, estimated vacancies in NHS Wales are at 5,700, a vacancy rate of 5.8%. The Healthier Wales plan is a ground-up strategy which involves health boards identifying the number of staff they project will be required in 3 years' time. Centrally, the figures are collated and a recommendation is made to government. This is the benefit of being informed by local need, but a longer-term strategy is required beyond the 3-year window, and greater revision and investment is urgently needed to overcome present shortages. Clearly, recommendations also need to address the ageing healthcare estate, including the need for more single occupancy rooms, larger corridors, modern oxygen pipelines, and effective ventilation of buildings and ambulances. My lady, we turn to dynamic staffing capacity. Even with better standing capacity, there may well be a role for surge capacity in a pandemic. We invite scepticism as to whether the Nightingale-style model of large temporary field hospitals divorced from existing infrastructure is the best way to achieve that. There has still been no credible explanation as to how the 10,000 additional beds created in England would have been staffed at a time when capacity within existing hospitals had already been stretched to its limit. Even after all the witnesses and thousands of documents, there is no clear idea as to where trained clinicians were going to come from or how tens of thousands of volunteers would be operationalised. There has been passing reference to training military staff or even airline staff. The reality, we suggest, is that it was a project driven by politicians who, at least at the time that Nightingales were commissioned, misunderstood that the limiting factor was not one of physical beds, but one of staff. Redeployment of staff may be a necessary feature of surge capacity. The lesson is that harms arise for staff and patients where there is widespread and inappropriate redeployment. As one physiotherapist told the TUC, the process of redeployment for physiotherapy staff was chaotic and took no account of clinicians' experience or substantive role. Whilst in my redeployed role, she said, no one contacted me to find out how well I was functioning. I had no acute ward experience for many years. I heard reliable accounts of redeployed professionals administering injections when not qualified to do so, and other situations where they acted beyond their competence. She says she was asked to do things clinically which are outside of her professional competence and had to refuse. It is important and should feature in recommendations that redeployment, including processes for risk assessment, training and oversight, should feature in pandemic planning. Next, the issue of precarious work in the NHS. During any pandemic, precarious work becomes a threat in terms of transmission and disproportionate impact. Effective infection prevention and control relies on workers who are trained and empowered to follow safe systems of work, who feel confident to sound the alarm when those systems are ineffective or not being followed, and who do not fear being penalised financially or otherwise for isolating when necessary. That, as we understand it, is the basis for Professor Whitty's observation that in seeking to ameliorate disproportionate impacts, what would have been actually more helpful, he says, is to make the employment of people less precarious during COVID, which solves the problem in a much more sensible and fundamental way. A significant and vulnerable section of the healthcare workforce is not directly employed. Anecdotally, it is understood that this group is disproportionately black, Asian and minority ethnic as compared to the directly employed workforce and more likely to be in low pay, both identified as risk factors in respect of COVID-19 and likely to be so again in the next pandemic. Indirectly employed staff, especially agency and outsourced workers, are more likely to have poor or no sick pay provision. They are more likely to face pressure, bullying or harassment from employers who face less scrutiny and regulation than NHS trusts and health boards. Presently, the indirectly employed workforce is a blind spot for those responsible for the services these workers deliver. We have heard evidence that NHS England does not hold any data on outsourced staff. Indirectly employed workers are not accounted for in the workforce plans or race equality strategies. Sarah Gorton, in her evidence on behalf of the TUC, explained the difficulties this presents during a pandemic in ensuring that terms and conditions negotiated for the indirectly employed workforce are actually afforded to them in practice. Greater visibility and oversight of the indirect workforce must therefore be achieved in advance of a future pandemic, such that measures designed to combat it may take account of and actually reach the full workforce. The TUC and its affiliates consider that outsourcing is a product of short-termism, a solution aimed at reducing costs which results in poor working conditions for which trusts, health boards and centralised management are absolved of responsibility. Interestingly, between 2008 and 2010, in Wales, Scotland and Northern Ireland, cleaning services were brought back in-house, with the key argument being improved infection prevention and control associated with in-house services. In a similar vein, the Equality and Human Rights Commission, in its 2022 report on the treatment of lower-paid ethnic minority workers, noted examples of outsourced NHS services being brought back in-house in England. One trust, it noted, was bringing cleaning and catering back in-house to boost workforce equality and support staff from ethnic minority groups. The TUC, for its part, would strongly recommend that a policy of insourcing is pursued in advance of a future pandemic. At the very least, we say, 3 steps must occur. First, there needs to be greater visibility of the indirectly employed workforce. Trusts and health boards should be obligated to collect from agencies and outsourced workers the same workforce information held about directly employed workers and share it with NHS England and its counterparts in devolved nations. Second, the indirect workforce, once visible, must be included in workforce planning, the workforce race equality standard, and other measures of workforce safety and equality, staff surveys, and, of course, pandemic planning. Clear plans must be in place to ensure that the indirectly employed workforce receives good quality IPC training, PPE and risk assessments, and promptly receives updated IPC guidance. Third, work needs to be completed to ensure that mechanisms of social partnership reach the indirect workforce and that trusts and health boards can ensure, for example, that if full sick pay for indirectly employed workers is agreed during a pandemic, it is actually implemented on the ground. The migrant workforce faces additional layers of precariousness, due in part to conditions of work attached to their visas and their employer's role in their legal status in the UK. It is a part of the workforce less likely to feel able to raise concerns, to demand risk assessments, PPE and IPC training, and is more likely to fall into presenteeism when self-isolation is required. We consider that there are practical steps to be set out in our written submissions around visa conditions and sponsorship, which would protect migrant workers and the wider workforce from transmission of the virus. Penultimately, we turn to regulatory response in the pandemic. The Health and Safety Executive, for entirely proper reasons, focuses its inspection activity on high-risk sectors, which ordinarily means that healthcare is not afforded the same level of intervention as, for example, manufacturing. However, in a pandemic with high levels of hospital admissions and fatalities, a healthcare setting can move from being a relatively safe workplace to a uniquely dangerous one. but HSC inspections in the years of the pandemic remain very low. During the pandemic, the HSC conducted over 400,000 spot checks and spot inspections, but only 483 of those were in the healthcare sector, 0.1%. Additionally, there is the problem of underreporting under RIDDLE. As a result, the HSC did not have the insight into the healthcare sector in order to direct its regime of proactive inspection or identify and remedy systemic problems. We consider that a number of recommendations are required to ensure that the HSC is required and able to pivot at the outset of a pandemic affecting the healthcare sector to provide proactive inspection, that the RIDDLE system functions in a consistent and meaningful way, and that the workforce regulator actually knows when a healthcare worker dies of a virus which they are far more likely to be infected by because of their role. Finally, my lady, vaccination is a condition of deployment. Significant evidence received in this module has underlined the damaging effect of the pursuit of vaccination as a condition of deployment in the NHS. Proponents of the policy say that the risk-benefit analysis falls in favour of the policy because the issue is one of saving lives. But that misses the point. Increasing vaccination uptake in the healthcare workforce is important, but this can be achieved through methods of provision of information and access, support and encouragement. Rates of vaccination observed in the devolved nations' health and social care workforces, where such a policy was not introduced, are evidence of this fact. An approach of encouragement is also consistent with the principle of informed consent which underpins the UK's vaccination strategy. It is clear from the data that in the COVID-19 pandemic, Black, Pakistani and Bangladeshi groups had lower uptake of the vaccine. Studies, including those outlined by Dr. Habib Naqvi, found that higher levels of hesitancy amongst some minority ethnic groups can be linked to concerns about the number of minority ethnic people included in clinical trials and fears stemming from historical unethical research. To simply mandate the vaccine to workers is to fail to reckon with the underlying causes and risks exacerbating them. There are powerful arguments of principle against vaccine as a condition of employment at all. Even if those are rejected, the balance of value and cost of such a policy will be influenced by factors such as the characteristics of the particular virus, the efficacy of the vaccine against transmission, and the stage of the pandemic. Any recommendation on this topic must reflect those factors and that nuance. We also suggest that it should await the end of Module 6, given the relevance of the issue to the social care workforce. My lady, those are our submissions. Earlier this morning, you've noted that on a number of occasions you've been challenged to be bold in your recommendations. That reflects, my lady, that the fundamental problems which resulted in avoidable loss of life in healthcare, which we have seen in this module, inevitably necessitate bold action. Thank you.
I'm very grateful, Mr. Jacobs, as helpful and constructive as ever. Thank you very much. Mr. Henderson.
My lady, you have heard a huge amount of evidence in this module, and like others, I commend all those who've submitted and given evidence, and your ladyship and the whole inquiry team for your diligence in absorbing the mass of material that you've had. In my closing statement on behalf of the Academy of Medical Royal Colleges, which represents the medical Royal Colleges and faculties across the UK, I want to focus on what we believe the inquiry should be seeking to achieve, and then what we believe are the key themes the inquiry needs to address. The inquiry must surely be more than a record of what happened, of who did what and when. It must also be more than just ascribing responsibility for what was or was not done. it must also seek to avoid inappropriate retrospective judgments. It must surely primarily be about learning lessons and should provide practical recommendations for the future to minimise harm in a future pandemic or emergency. And we know it is highly likely there is going to be another pandemic in the future. We can also be pretty sure that a pandemic of an unknown disease will cause casualties. People will fall ill and people will probably die because of the disease. There will also be collateral damage. Necessary treatments will be cancelled or delayed. People will be unable or unwilling to access appropriate care. This will have its own consequences and its own casualties. That was the case in this pandemic. It was the case in previous pandemics. It was inevitable, and it will happen again. Eliminating all risk and danger is not possible. However, the great gift of this inquiry is, and what it can bring, is identifying what we can do before and during any future pandemic so that harm and casualties are minimised, and ensuring we are sufficiently prepared to take the right actions so that the suffering felt by so many in COVID-19 is not repeated. In our original submission, an opening and written and oral statements, the Academy made a series of 12 recommendations. They were based on the expertise of our member organisations, who in turn drew on the experiences of their individual doctor members who worked on the front line of health services throughout the pandemic. We believe and continue to believe that the considered views and experience of medical practitioners are valuable and essential in both the planning and management of pandemics and in the learning of lessons for the future. We have not heard anything during these evidence sessions which would lead us to substantially amend those recommendations, and we hope the inquiry will adopt them in its report. In this statement, however, I'm not going to simply repeat those recommendations. Rather, we have sought to pull them together with other lessons we've heard from the evidence into some overarching themes which we believe the inquiry should address. The 4 themes we have identified are preparedness, responsiveness, learning, and transparency. I will briefly look at each of those in detail. Preparedness. Your Ladyship has already reported on the overall state of preparedness at a national level. That preparedness applies equally within the health services. There are things which need to be in place and current before any other pandemic starts. In terms of our recommendations and the evidence that you have heard, this means capacity. As we've heard, it is essential there is sufficient capacity in both workforce and bed numbers in the system to be able to manage future pandemics. As has been stated by other people today, that is still not the case. Testing policy. There must be a clear national strategy setting out the purpose, benefits, and indeed limitations and delivery of testing. Involvement in planning. There has to be full involvement of relevant professional and clinical bodies in pandemic planning. And this includes plans for supporting care homes and for considering the mental health consequences for public and staff. IPC strategy. There must be an up-to-date infection protection and control strategy, which can be flexible enough to meet the particular circumstances of a future pandemic. This includes having sufficient stock of PPE. And workforce strategies. We must have in place clear plans for the deployment of staff, retaining and bringing in additional capacity. Second, responsiveness. This relates to the activities which need to happen during a pandemic. Most of these, in effect, entail effective implementation of the strategies identified in the preparedness phase. And this includes agile and flexible crisis management, including deployment of resources in response to geographical variation and efficient delivery of any vaccination or treatment programme. Engagement, early and regular and continuing engagement with clinical professional bodies. Efficient staff recruitment, deployment and redeployment. Staff support in terms of both practical and psychological support. The effective distribution and use of PPE, and then rather more broadly, effective communications, clear and consistent public health messaging across 4 nations, and importantly, political consistency of wider messaging. Different messaging and approaches across the 4 nations did cause and would cause difficulties for the public and for healthcare professionals. Thirdly, learning. We have to ensure shared learning between providers, between research bodies, professional organisations and government. Next, in terms of clinical advice, we must ensure for the future that any advice professional bodies produce aligns with accepted nationally agreed guidance, or where there is genuine difference of clinical opinion, and that may well be the case, that this is evidence-based and clearly set out and explained. And then ensuring that we protect clinical education and training. We've not heard about this much, but it is vital both to maintain the future supply of health services and the continuing supply of health professionals, that education and training is not ignored and not lost. It may have to change how it's delivered. Some things may have to be on hold, but we cannot ignore education and training. And finally, transparency. That is, for all involved being transparent about the state of affairs, avoiding both rose tinting and doom mongering, both of which I believe we saw during the pandemic. And then honesty on what can and cannot be achieved. Crucially, transparency, honesty and engagement must be at the heart of any government's management of future pandemics. Any erosion of trust will always have a negative impact and negative consequences. So, in conclusion, my lady, these are the considered recommendations of those with direct knowledge and understanding of the pandemic. And we will expand on these recommendations in our written submission. We do not believe we can eliminate risk and harm in a future pandemic, but we do believe if the inquiry adopts our recommendations, and crucially, if they are then implemented by government and other relevant bodies, we could significantly reduce the harm for patients, public and staff in any future pandemics. Thank you, my lady.
Thank you very much, Mr. Henderson. Very grateful to you for your thoughts. Ms. Sen-Gupta.
Thank you, my lady. As your ladyship knows, the Frontline Migrant Health Workers Group is comprised of 3 organisations: United Voices of the World, UVW, Independent Workers' Union of Great Britain, IWGB, and Canlungan. The group sincerely thanks your ladyship and the inquiry team for giving their members the opportunity to participate in Module 3, allowing them to give evidence to your ladyship, to ask questions of other witnesses and to make submissions. The importance of frontline migrant health workers during the pandemic and the disproportionate impact on them has rightly become a key feature of the evidence during Module 3. The group wishes to emphasise that systemic issues, like outsourced employment, are applicable across the working class as a whole, regardless of ethnicity. A persistent and recurring theme in the accounts of outsourced and migrant workers is that they had no voice throughout the pandemic. They could not speak out for fear of the consequences for their employment and their immigration status. Even when they did speak, no one listened. These accounts are borne out by the evidence in this inquiry. In the thousands of pages of documents disclosed by the massive organisations that make up the healthcare system, there is barely any reference to them at all. The standout feature of the evidence is that even when they were making the ultimate sacrifice, outsourced and migrant workers were routinely overlooked. IWGB, UVW and Canlungan gave their members a voice. This inquiry has also given them a voice, for which we are grateful. My lady, we addressed our opening submissions by reference to the slogan of the Johnson government, "Stay at home, protect the NHS, save lives." We emphasised how our clients' members could not stay at home and how they worked as part of the NHS healthcare system in order to save lives. We address our oral closing submissions by reference to 3 periods of time: before the COVID-19 pandemic, during the pandemic, and the future. Pre-pandemic failures. Your Ladyship has addressed the pre-pandemic position in Module 1 on preparedness. Lord Darcy has also recently undertaken a review of the NHS. He described how the resilience of the UK had been worn down by the chronic underinvestment and the most austere decade of funding in the NHS that preceded the pandemic. He also described a chronically weakened system with downgraded capacity and capability, with higher bed occupancy rates and fewer doctors, nurses, beds and capital assets than most other high-income health systems. At the same time, many of the social determinants of health, such as poor quality housing, low income, insecure employment, have moved in the wrong direction over the past 15 years, with the result that the NHS has faced rising demand for healthcare from a society in distress. The NHS was left underfunded, under-resourced and understaffed, and the underlying health of the nation has declined significantly. Underfunding contributed to a rise in outsourced labour, particularly in non-clinical workers. NHS trusts believed that outsourcing would cut some of the costs that they had been forced to cut. When the pandemic hit in early 2020, around half of the UK's hospital sites had outsourced ancillary services. Outsourced workers were earning poverty wages and working more than one job in different locations, but with none of the contractual protections of in-house employees. Understaffing led to an increased reliance on migrant labour. Clinical and non-clinical staff were recruited from overseas, but the policies and narrative of the hostile environment guaranteed their exposure. Their visas were wholly dependent on their continued employment, making them pliable and vulnerable. Their visa conditions excluded them from accessing the public funds that their British colleagues were entitled to. This low-income, insecure employment is precisely what Lord Darcy was referring to. The social determinants of health have moved in the wrong direction in society as a whole. But critically, they've moved starkly in the wrong direction within the healthcare workforce, the very workforce that exists to protect the rest of us. During the pandemic, the group's members experienced the pandemic as part of a second tier of the healthcare workforce, the lowest paid and in the most insecure employment. The pandemic magnified these issues. Your Ladyship heard compelling evidence from Alex Marshall, President of the IWGB. He told the inquiry that the pandemic poured petrol on an inferno that was already blazing. All of the group's members had to work during the pandemic. There was no furlough for the frontline migrant health workers. The nature of their work meant that they were inevitably exposed to infection. The nurses working directly with patients and delivering care, hospital cleaners and porters spending prolonged periods in wards doing physical work, hospital security guards also spending prolonged periods in hospitals, sometimes undertaking additional physical tasks such as portering. Medical couriers entering hospitals and returning to a central hub with other couriers who had also recently entered hospitals before moving to a different hospital and repeating the process. Taxi drivers contracted to transport healthcare workers and patients to and from hospitals, spending prolonged periods in the confined space of a vehicle. They were all hospital workers. The two-tier worker system manifested itself in a number of ways during the pandemic. Witness 1, a hospital cleaner, gave direct evidence of the experience of many thousands of outsourced migrant workers in relation to PPE. When gowns, aprons, gloves, and better masks were provided to in-house staff, she was allowed a single FRSM at the beginning of her shift. She had no one to ask for better protection. She had to take better PPE. When clinical employed NHS staff received PPE, training late, outsourced workers like W1 often received no training at all. Risk assessments also often did not happen at all. If they did, they were consistently late or inadequate. In W1's case, neither her hospital managers nor her outsourced employers ever asked a single question about her welfare. Outsourced non-clinical staff were regularly in the lowest priority categories for testing and vaccination. Migrant and outsourced workers were pressured into working in higher risk environments. They were unable to say no because of their precarious employment and/or immigration status. The system of sick pay was so inadequate for outsourced workers that they had to choose to go into work and risk lives or stay at home and face potential destitution. Your Ladyship heard powerful evidence from W1 that had she become symptomatic, she would have had to continue working. These workers knew that they were vulnerable. They knew that they were working with patients who were vulnerable. Their underprotection and overexposure had implications beyond their own welfare. It heightened the risk to those around them. It was a major failing in the whole IPC process. These workers raised warnings on these issues, either individually or through organisations like Canlungan and unions like UVW and IWGB. At no point were any of them listened to. The devastating impact on them was inevitable. From higher infection rates and higher incidence and severity of long COVID to the truly shocking mortality rates, they're worth repeating. Up until the 22nd of April 2020, 63% of the healthcare worker deaths were ethnic minority workers. And of that 63%, at least 83% were migrants. 36% of those migrant deaths were workers from the Philippines. That was by far the highest national mortality rate for migrant health workers. The ONS occupational data from May 2020 flagged these outsourced gig economy, low-income occupations in the highest mortality categories: healthcare assistants, care workers, cleaners, security guards, and drivers. Public Health England's June 2020 report, Disparities in Risks and Outcomes, repeated those findings. Occupations with the highest infection and mortality rates were those with the highest exposure and the lowest pay. Migrants had significantly higher mortality rates. The impact was clearly predictable. Low-paid workers living in the most deprived areas, in multi-occupancy, low-quality housing, and packed into public transport were going to be hit hard. When their work is essential and exposed, they were going to be hit harder still. When their work is made precarious by immigration conditions or a lack of contractual protection, they were going to be hit the hardest of all. As Professor Sir Chris Whitty said, poverty is a risk factor for infections everywhere. The government response was characterised by silence and inaction. The first layer of silence was the data. The ONS data was considered the gold standard by many of the witnesses, but it did not include the deaths of any workers who arrived in the UK after 2011. Almost a decade's worth of migrant workers were not even counted. Filipinos are the largest national group of workers in the NHS, behind British and Indian workers. No official data was gathered on infection and mortality rates in Filipino workers. No official data was gathered in respect of migrant mortality rates. Subcontracted staff were not represented in the NHS datasets. The DHSC, the department responsible for healthcare workers, did not even include workers like cleaners in its data on healthcare worker mortality. The true picture of outsourced and migrant mortality would have been significantly higher than that recorded. Despite these data inadequacies, the impact on migrant and outsourced workers was clear enough. But nothing changed. Mr. Hancock confirmed that he was aware from the spring of 2020 that migrant workers were suffering disproportionately high mortality rates. But your ladyship will recall that his attempts to explain why he took no specific steps in relation to that group were extremely weak. The future. The Race and Health Observatory is focused on tackling ethnic and racial inequalities within the healthcare system. But even their reports have a distinct lack of consideration for the immigration status of the workforce. Lord Darcy, reliant as he was on reports from that observatory, makes no reference to the impact of immigration status or precarious employment within the healthcare workforce. Across the board, the evidence has shown that these categories of worker were not considered. They were left exposed and unprotected. There is a lack of accountability, a culture of blame shifting, and a health system that is structured in such a way that responsibility is impossible to pin down. That was encapsulated by CTI's very pertinent question to Alex Marshall. If you're an outsourced worker or a migrant worker, who do you complain to? Within the UK health system, even responsibility has been outsourced. Recognition from Dame Jenny Harris and Professor Stephen Powis that risk assessment and IPC measures must be applied consistently and equally across the NHS workforce, whether employed or outsourced, is welcome. But this must translate into concrete change, where responsibility for a safe working environment clearly lies with a single entity and subject to regulatory sanction in the event of a breach of health and safety law. The owners or managers of the workplace where the risk exists, i.e. the hospitals, are best placed to assess and mitigate that risk. The simplest and most effective way of ensuring consistency and equal treatment, leading to a serious reduction in the risk to healthcare workers and the public, is to bring outsourced health workers in-house. It is overwhelmingly clear that if there were another pandemic tomorrow, the low-paid, precariously employed migrant healthcare workers would continue to die at the same significantly higher disproportionate rates. Both Mr. Hancock and Sir Sajid rightly acknowledged the importance of the frontline outsourced workers. The importance of these workers needs to be fairly reflected now so that they are not in the same position during the next pandemic. To have a two-tier healthcare system where some workers are more exposed than others because of their employment contracts or immigration status, despite doing the same jobs in the same hospitals, is a fundamental injustice. as Alex Marshall pointed out, it is also a public health issue. Exposing these workers exposes their communities and their patients. This is one of the key lessons learned. The primary recommendation sought by the Frontline Migrant Health Workers Group is for an end to this two-tier system of health workers. Professor Sir Chris Whitty told your ladyship that part of our preparation for the next pandemic is to reduce the vulnerability of the people we already know are vulnerable. In his words, what would have actually been more helpful is to make the employment of people less precarious. Reducing economic precariousness is one of my strong recommendations to my successors, he said. Within the healthcare system, that precarious employment has to end now. My lady, we respectfully submit that healthcare workers must be directly employed by the NHS hospital trusts they work in. Migrant healthcare workers must enjoy the same protections as their non-migrant colleagues. We need to ensure that they are not ignored by the NHS and by government in the future. My lady, frontline healthcare workers protect us all. We need a healthcare system that also protects them. Thank you, my lady.
Very grateful, Ms Sengupta. Thank you very much. Mr Thomas, if you'll forgive me, I think we'll break now and come back at 10 to 2 to hear from you on behalf of FEMHO. Sorry to cut you off in your prime.
My lady, I'm sorry to interrupt, but I suspect Mr Thomas may not be able to be here this afternoon and is rather keen to address you before lunch. I'm so sorry.
No, sorry, that message had reached me, Mr Thomas. If you're in difficulties this afternoon, of course, carry on now, please.
Thank you, my lady.
I'm grateful, my lady. My lady, as you know, I represent FEMHO. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. Those were the words of Martin Luther King Jr. before the Second Convention of the Medical Committee on Human Rights in March 1966. This inquiry's legacy begins by confronting an uncomfortable truth. The fact that the pandemic laid bare the pervasive inequities in our healthcare system, inequities that left ethnic minority healthcare workers on the front lines, ill-equipped, unsupported, and ultimately betrayed by the institutions they served and that were there to protect them. These devastating outcomes are not mere coincidences or unavoidable tragedies of a global crisis. Instead, my lady, they were the foreseeable results of systemic neglect, historical inequalities left unremedied, and a healthcare system deeply entrenched in structural and institutional racism, a pernicious form of discrimination that we must confront, however uncomfortable that confrontation may be. You see, the racism was not only perpetuated by explicit action, but also by omission. It manifested in decisions made, decisions deferred, and decisions never even considered. It resulted in preventable harm and suffering, lives lost and communities left without the support they so desperately needed. The healthcare system's failure to protect ethnic minority healthcare workers was, at its core, a failure of accountability, leadership, and the moral imperative to value every life equally. Yet, this inquiry must do more than just note this reality. It must ask and answer a fundamental question. Why? Why was this allowed to persist? And why did it take a pandemic to expose it so starkly? After all, there have been numerous reports and recommendations made on many of the underlying issues that have failed to result in positive change. The answer lies in systemic failings, historical neglect, and an unwillingness to face hard truths until human cost became too great to ignore. This inquiry has the potential to be a turning point. It's a chance to confront these failings, to understand why they happened, and to ensure that lessons learned lead to meaningful change and meaningful reform. Milady, structural and institutional racism are the elephants in the room. During the pandemic, these were not abstract concepts, but lived realities for thousands of Black, Asian, and minority ethnic healthcare workers. They manifested in policies, practices, and systems that disadvantage ethnic minorities, particularly during a crisis. The pandemic exposed deep-rooted deficiencies within the NHS and public health systems, which were too ill-equipped and lacked the inclusivity needed to protect all workers equally. There were data failures. The failure to collect robust ethnicity data was a fundamental flaw, made more egregious by the wealth of evidence that this was a known issue prior to the pandemic. Inadequate collection of ethnicity data hindered the ability to identify disparities and delayed targeted interventions, with decision makers preferring to wait for more data rather than take action on what they were seeing and hearing alone. Communication gaps. Public health messaging often failed to reach ethnic minority communities due to cultural insensitivity and linguistic barriers. This was a systemic neglect that led to mistrust and ultimately poorer health outcomes. Vaccine hesitancy among ethnic minority groups, for instance, was compounded by these ineffective communication strategies. Branding ethnic minority groups as hard to reach is particularly unhelpful, however convenient and easy a response it is. As Professor J.S. Bamra put it, it sends the wrong signal because it implies that the problem is with you and not with us. The lack of ethnic minority representation in decision-making bodies further compounded these issues. Policies were developed without the voices of those most affected, leading to one-size-fits-all approach that ignored or at best misunderstood the unique challenges faced by ethnic minority communities. Milady, behind every statistic is a human story, a life impacted, a family grieving, a community left vulnerable. Healthcare workers who lost their lives or endured severe illnesses were not just numbers, they were individuals who deserved protection and respect. To give proper context to this inquiry, it is essential to define two key concepts that underpin much of the evidence we have examined: institutional racism and structural racism. These terms are not interchangeable. Understanding their distinction is critical to understand how systemic inequalities operated during the pandemic. Let me turn to institutional racism. This refers to the policies, practices, and procedures of institutions that intentionally or unintentionally produce outcomes that disproportionately disadvantage certain racial or ethnic groups. It operates within individual organisations such as healthcare trusts and manifests in inequitable outcomes and due to biases embedded in processes and practices. During the pandemic, institutional racism was evident in deployment practices, access to PPE, exclusion from decision-making, whereas structural racism encompasses the interconnected societal systems and structures that perpetuate racial inequalities. It's reflected in the cumulative effects of inequities across sectors including health, education, housing, and employment. And during the pandemic, structural racism operated as a backdrop backdrop, amplifying the vulnerabilities of ethnic minority healthcare workers. And we can see that in the socioeconomic disparities. Many Black, Asian and minority ethnic workers live in areas of high social deprivation with limited access to healthcare and poorer living conditions. And these factors increase their susceptibility to severe COVID-19 outcomes. Milady, why definitions matter? Understanding institutional and structural racism is not just an academic exercise. These concepts provide a framework for examining how and why ethnic minority healthcare workers were disproportionately affected. They also offer a roadmap for systemic reform, underscoring the need for accountability. Institutions must confront their role in perpetuating inequities and commit to transformative change. Equity-centred planning, future public health strategies must actively dismantle structural barriers and embed equity at their core. Inclusion. Ethnic minority healthcare workers and communities must be central to decision-making processes to ensure that their needs are met. Milady, the intersectionality of race, class and gender further exacerbate their plight. Many ethnic minority workers lived in overcrowded or multi-generational households where the risk of transmitting the virus to vulnerable family members was heightened. For women, often balancing caregiving roles with frontline duties, the strain was particularly acute. Economic disadvantage and limited access to resources such as safe housing or alternative care options compounded the risks they faced daily. These disproportionate outcomes were not inevitable. They were the predictable result of systemic neglect. Public health strategies largely ignored the socioeconomic and structural determinants of health that amplified vulnerabilities for ethnic minority workers. The tragic loss of life of the first 10 doctors should have been a wake-up call. We heard that the first 10 doctors were doctors of colour. Instead, it highlighted a healthcare system unprepared to protect its most vulnerable workers. Addressing these inequities requires systemic change, not token gestures, to ensure that such devastating disparities are never repeated. My lady, our written submissions will address these recommendations in details. At this stage, we set out the key themes emerging from Module 3 that need to be addressed. The failures in PPE. This wasn't just a logistical failure. It was a failure in the moral commitment to equity and inclusivity within healthcare. Workers faced a cruel dilemma. Choose between personal safety and deeply held religious beliefs. Barry Jones spoke of how powered air purifying respirators hoods could have been a viable solution, one that did not require fit testing and avoided the exclusionary effects of traditional FFP3 masks. Yet, these hoods, despite their effectiveness, were not pursued by decision makers at the highest levels and were really made available. Many ethnic minority healthcare workers who were overrepresented in high-risk roles, such as porters, cleaners, frontline nurses, often reported delay or shortages in accessing suitable PPE. Fiona McQueen testified that the non-clinical roles included porters and cleaners were often the last to receive adequate PPE. In the face of such systemic neglect, many others took it upon themselves, milady, to repurpose materials for makeshift PPE, driven by desperate need to protect themselves. PPE stockpiles procured did not account for the diverse facial features and were largely based on the Sheffield man face, a standard white male face shape that did not reflect the diversity of the healthcare workforce. Such oversights highlight a broader failure to prioritise the safety of vulnerable groups in healthcare planning. Then there was equipment inadequacies. The pandemic also exposed inadequacies in medical equipment, such as the pulse oximeters being a stark example, designed and tested without consideration of darker skin tones. These devices frequently provided inaccurate readings for ethnic minority patients. This was a well-known flaw that had existed for years and went unaddressed despite research consistently showing the devices to be less reliable for people with darker skins. The NHS Race and Health Observatory, through the testimony of its CEO, highlighted how the use of these devices led to delayed treatment for ethnic minority patients, ultimately worsening their health outcomes. And as Sajid Javid himself noted at the time, this may well have resulted in deaths. So what does this tell us? It reveals a troubling lack of accountability in design, procurement, and evaluation of medical devices. It shows that the healthcare system failed to challenge or question whether the tools it relied on were suitable for all populations. The reliance on the one-size-fits-all approach in medical equipment and protective gear meant that the healthcare systems tactically endorsed practices that placed ethnic minority lives at greater risk. But, milady, this is not just about flawed devices. It's about a flawed system that tolerated inequity in its operation. The failure to address these shortcomings sooner demonstrates a systemic disregard for the unique needs of minority populations, a disregard that should never have been acceptable. Inadequate risk assessments. Risk assessments that could have identified specific needs, but were often a tick box exercise. Ruth May mentioned that despite her push to speed up risk assessments for ethnic minority staff, many were left unprotected in the meantime. There was no national standardisation of these risk assessments, and the lack of targeted measures to protect high-risk groups left thousands exposed to the worst effects of the virus. Even where risk management protocols were designed, their implementation was inconsistent across healthcare settings. Some organisations acted swiftly to mitigate risk, conducted thorough assessments and provided accommodation such as redeployment or enhanced protective measures. However, others failed to adopt such measures uniformly, failing to achieve effective outcomes, leaving gaps in protection for those most in need. This patchwork approach underscored a lack of a centralised accountability and oversight. Let me turn to long COVID. The pandemic's long-term effects, particularly long COVID, have disproportionately impacted ethnic minority healthcare workers. These workers not only faced heightened exposures to the virus, but now endure lasting health complications at greater rate. Preparedness and future planning. The pandemic revealed glaring gaps in preparedness, particularly equity-focused planning and resource allocation. Ethnic minority healthcare workers were disproportionately affected, not because the virus discriminated, but because the systems meant to protect them failed to account for pre-existing inequities. The absence of inclusive planning in pandemic responses, such as equitable stockpiling or of resources and culturally competent policies, exacerbated these disparities. Accountability. Accountability is pivotal in addressing systemic inequities that plague the pandemic response. Equally concerning is the lack of robust accountability frameworks to address these disparities. Despite numerous reports highlighting the disproportionate impact of COVID-19 on ethnic minority healthcare workers, there was little evidence of timely or decisive action to mitigate these effects. Data collection and transparency. The inadequacies in ethnic-based data collection during the pandemic severely hampered the ability to develop effective public health responses. A standardised approach to data collection is urgently needed. Inclusive tools that accurately capture ethnicity-related metrics must be prioritised. Milady, let me turn to the impact on mental health. Ethnic minority healthcare workers face disproportionate mental health challenges during the pandemic, reflecting the compounded effects of systemic inequities on frontline exposures. The heightened risk of infection combined with witnessing disproportionately high mortality rates among colleagues and patients took a significant toll on mental well-being. So, Milady, let me come to my conclusions. FEMHO closes with a stark truth. Ethnic minority healthcare workers and communities bore a disproportionate burden during the pandemic, not merely as a consequence of individual failings or oversight, but rather as a result of deeply entrenched structural and institutional racism within our healthcare system. These factors intertwine to create this impact, which was not novel or unexpected, but in contrast were the inevitable outcomes of known issues. FEMHO workers were not only disproportionately frontlined, they were disproportionately forgotten. So what can we do? This is not about simply improving processes or updating procurements. It's about a fundamental rethinking of what equity means in healthcare. It's about ensuring that healthcare systems do not treat patients, but also care for those who deliver that treatment, whatever their ethnicity or outcome. It's about a commitment to making healthcare not only technically competent, but culturally competent. This means investing in research to develop medical equipment that works for all populations. Milady, as I come to the conclusion, this is not just a story about failures, it's a call to action. FEMHO urges this inquiry to adopt the forward-thinking solutions that have been proposed, embedded in equity, in pandemic preparedness, addressing the disparities through accountable leadership, a culturally competent care. These are not just recommendations, but these are necessities if we are to build a healthcare system that values life equally. It's not about just finger pointing, it's about ensuring that we do not repeat the mistakes of the past. The pandemic was a devastating chapter, but also offers, Milady, an unprecedented opportunity to rewrite the narrative of the healthcare in this country. So as I conclude, as we leave this room, let us not leave the lessons behind that we have learned. Let us commit to a future where all healthcare workers are valued for their skills, not discriminated because of the colour of their skin, where no patient is left unseen, where no community is left unheard. Let this inquiry be a turning point, a moment where we finally say enough. Enough of systemic inequities, enough of avoidable harms, enough of lives being lost to racism and neglect. This is our charge, and this is your moment to lead. Let us not waste it. Thank you, Milady.
Thank you very much indeed, Mr. Thomas. As I expected, another very powerful piece of advocacy. I'm very grateful to you. Right, we shall adjourn now, and I shall return at 2:10.
Thank you.